A very good morning to dear faculty members, colleagues, and dear residents and all those who are connected with us online. We are gathered here to commemorate World Ovarian Cancer Day. On this occasion, I take pleasure to say that today we are proudly carrying forward what we had started last year, which is Gynecological Pathology Lecture Series. So today is the second part of that series. In this heading, we aim to teach and learn various aspects of gynec pathology. We also aim to start gynec pathology PTCC course in the current year, which is in pipeline and being streamlined. Under able guidance of our Vice Chancellor, Lieutenant General Police Sir, Vipin Puri Sir, and our Head of Department, Professor U.S. Singh Sir, we hope to carry this vision forward. With this background, I welcome our brilliant speaker, Dr. Divya Mida, who is Senior Consultant in Department of Oncopathology, Tata Medical Center, Kolkata. Dr. Divya has been associated with Tata Medical Center since its inception, first as a postdoctoral fellow in 2011, and then as a consultant 2012 onwards. She has been associated with Kidwai Cancer Institute and Nimhans, Bangalore, and has been an integral part of working team of Thalassemia and Sickle Cell Society, Hyderabad. She has special interest in gynecological pathology, uropathology, soft tissue pathology, and cytology. She also has a vast research experience and numerous national and international research publications in her areas of interest. As part of the Gynecological Disease Management Group, she is assisting in the System Medicine Cluster, which is SciMed, Cervical Cancer Screening Project, in the interpretation of cervical biopsies of patients who are positive for high-risk HPV DNA. She is playing active role in coordinating PDF oncopathology course and has been actively involved in guiding and mentoring the trainees in all educational activities. She also has organized subspecialty various conferences, CMEs, and workshops all over India and abroad, encompassing her areas of interest. Now, a few words about her department. Department of Oncopathology, TMC Kolkata, is involved in various research projects, including digital pathology system, automatic tissue microarray, multicolor IHC, laser capture microscope. These are various equipments which are add-ons to the department and they help in research. There are facilities to biobank fresh tissue in the extramural biobank facility to the hospital. So this is a big inspiration for our residents to pursue further PDF in TLC Kolkata. You can contact ma'am or us for any other activities. Welcome ma'am. She is one of the founder member of Society of Genitourinary Pathologists and Gynec Pathology Society of India, which is her recent venture. Well, the words fall short to describe her achievements. I am grateful to Dr. Divya, who has kindly accepted our invitation. I humbly request Professor U.S. Singh Sir to come forward and welcome Dr. Divya. So please come forward. I welcome Dr. B.K. Agrawal ma'am to please welcome. Take flower also for ma'am. Manish, take a picture. I welcome Dr. P.K. Agrawal ma'am to the lecture series. She's always been motivating for us and accepting our invitation to come. Thank you, ma'am. I request Dr. Divya to please come on the podium and enlighten us. She will be having an interacting session on endometrial carcinoma transitioning from morphology to molecular diagnosis. Residents please feel free to she'll be taking up questions also because she's full of knowledge. So please feel free to ask questions. Welcome.
Good morning, everyone. Greetings from TMC Kolkata. At the outset, I would like to thank Professor U.S. Singh and his wonderful team of pathologists and this huge family for having me here. Thank you, Dr. Vidhi, Dr. Shivanjali, Dr. Shalini, and all of you who have taken out time from your daily activities to come and listen to me today. It's an absolute pleasure. Normally, I speak to, confined GU interested or, gynae path interested groups, but to speak to students is something I enjoy most because the foundation begins there and then we grow from here. So thank you very, very much for having me here. All right. Now, straight going to the topic. There has been an exponential improvement in the understanding of the molecular pathogenesis of endometrial carcinoma. And this topic today, endometrial carcinoma, transitioning from morphology to molecular diagnosis, is very apt to every one of you here who is invested, interested, and are stakeholders in the management of endometrial carcinoma. Now, let me tell you something. When we begin pathology, we think we are just diagnosticians, isn't it? We sit behind our microscope and we think कि हमें सिर्फ diagnose करना है, treat तो कोई और करेगा, isn't it? But let me tell you something. Each and every one of you here, whether you are a pathologist, a histopathologist, a hematologist, or a clinical pathologist, is a clinician. Because on the basis of what you tell is how the patient is going to be treated. You diagnose well, the patient is going to be treated well. So whether there is an MD medicine or MS surgery or MD pathology, it's all the same. We are all clinicians, we are all investors, we are all stakeholders in patient care. So today's lecture is something like this. It's about how we pathologists, from morphology, we can't forget basic morphology, from morphology through IHC and then to moleculars, how can we contribute to good patient care? Because that's our ultimate aim, isn't it? So now let's begin with that. And let's go back a few years, say 30 years, 1983, when endometrial carcinomas were very simple. But then even at that time, in 1983, when there was only morphology, or kuch tha hi nahi, people would still see morphologically and identify two types of tumors, type 1 and type 2. They recognize that there are two types. One is endometrioid, and the other one is non-endometrioid. Now, for first years who are you here? Can you lift your hands up? Very good. So I'll be, it'll be like more of an interactive. I'll be asking questions. I don't judge. You just answer. Okay? So just feel free to answer and feel free to interject. Okay? So endometrioid. What do you mean by endometrioid? Oid means looking like. Something which looks like normal endometrium. So that they recognize on morphology. You don't need IHC to tell you that. It's looking like an endometrial gland. It is an endometrioid tumor. It doesn't look like endometrioid. It's non-endometrioid. So clearly, in 1983, pathologists were very clear. Endometrioid type 1, non-endometrioid, you can give them names, serous, clear cell which look clear, so type 2. How are they different? They understood that also. Endometrioid somehow under the microscope looked little low-gradish. Why low-gradish? It looked like the normal endometrioid glands, maybe fusing together. So they said, okay, they are low-grade. Serous looked angry under the microscope, pleomorphic, mitosis. 1983, everyone knows this. It's not rocket science. That this looks high-grade. Clear cell looks a little less pleomorphic, but definitely looks higher grade than endometrioid. So that was clear. Then they also said, okay, endometrioid, the background endometrium is hyperplastic. The background endometrium in serous and clear cell is atrophic. So why is this different? Because endometrioid occurs in a perimenopausal age group and non-endometrioid serous and clear cell occurred in age group and therefore atrophic background. Even the type of women were different. Type 1 or endometrioid was dependent on estrogen. They were obese women. Whereas the type 2, that is the serous or the clear cell, was seen in more thinner women. I mean, you don't say fat thin anymore, but their body habitat was different. And it was not estrogen dependent. Even the risk factors were different. For the endometrioid, they were diabetic, PCOS, nulliparous, late menopause. But the serous or clear cell then somehow fit into a particular risk factor. And overall, they found that the endometrioid did better, whereas the non-endometrioid, the serous and the clear cell, did worse. And between 1984 and say the late 2000s, they started studying the molecular genetics. And therefore, they found this, that even genetically, the mutations were found to be different. Type 1 had some other mutations, which I'm going to talk about later. Type 2 had some other mutations. But so this knowledge has been building since the 80s and then gaining momentum in 2000s. And finally, 30 years later, in 2013, there was a Cancer Genome Atlas study which was published in Nature, which gave us the molecular classification of endometrial carcinoma. And by molecular classification, I mean there were 4 non-overlapping groups. Now, go back to histology. When we look at endometrioid under the microscope, and some of us see clear cell areas, we can see that, right? And then you say, is it endometrioid and clear? Chalo likh deti hu, focal clear cell areas seen. Kya farak padta hai? I mean, it's better to be safe, right? Dusre college mein jayega, somebody will say it's clear cell. So there is ambiguity, there's heterogeneity. I used to do that, just to be safe. I want to be safe. I don't want the other pathologists to think I know less. So let me just write whatever I see under the microscope. Was that right? Was I right? So let's see if I was right or wrong. So then came molecular, which got a lot of objectivity to this subjectivity. 4 non-overlapping groups. They don't overlap. They don't say endometrioid with clear cell features, serous with clear cell features. Wo sab nahi hai. They are clear groups. One is the pole E ultra mutated group. This has mutations in the gene encoding the exonucleus domain of the DNA polymerase epsilon. This group has lots and lots of mutations. It's called ultra mutated, innumerable number of mutations, okay? That's the DNA polymerase epsilon gene, and the group is called pole E ultra mutated. This is one distinct group. Another group, the MMR deficient group. This had lots of mutations, but lesser than the pole E, and this was the hypermutated group. Then there was a group which was associated with mutations in the oncogene TP53 and was called the P53 mutant group. It had a lot of somatic copy number alterations, okay? And which did not fall into any of these 3 subtypes. That is, was not POLE, was not MMR, was not P53 mutant, automatically became no specific molecular profile. It's a diagnosis of exclusion of the top 3. So it's very clear now that these are non-overlapping, non-ambiguous groups. Okay? So, if you see this diagram, it shows you a relationship between the traditional type 1 and type 2. I discussed type 1. Type 1 is endometrioid, the low grade ones, endometrioid carcinoma grade 1 and 2. Type 2 is the non-endometrioid, clear cell and serous. There's something called type 3. Once the molecular was done and we went back to what the histology was, this is the relationship. Okay, so this shows the lines connecting the type, the histological type to the molecular type. So if you see, the thicker the line, the stronger the association. Now, is my cursor, can you see my cursor? So endometrioid carcinoma, grade 1 and 2, the low grade ones, map mostly thicker line to the no specific molecular profile. Okay? Go to this other end, serous carcinoma, maps with a very strong association with the P53 abnormal. Let's look at endometrioid, what you call endometrioid grade 3. What did it map to? What did it become? It could have been, some were no specific molecular, some was MMRD, some was poly, some was even P53 abnormal. So much heterogeneity in histology. What about clear cell carcinoma? Even when this was mapped, all your clear cell carcinomas, you subject them to all this. Even they were found to be molecularly all over the place. So the strongest association was seen with what you call low-grade endometrioid 1 and 2. They turned out to be most often no specific molecular type. And what you call truly serous turned out to be P53 abnormal. The rest was all over the place. So there is so much heterogeneity in morphology, whereas the molecular groups are totally non-overlapping. All right? Sorry? Yes. I'm going to come to that. I'm going to come to each of them. That's why I asked for a very long lecture. This topic, if you speak slowly, it makes a lot of impact, is what I felt, rather than if you rush, it doesn't really make an impact. So if you give me time, I'm very happy to speak on this for another hour, even an hour, 15 minutes, okay? So what you see on this picture is WHO, the old one, 2014, and the new one, 2020. Now, if you see the classification in 2014, that is this dark blue book, it is a histology. I'm not going to talk about, I'll tell you each name right now, but if you see this list here, it is a histological classification. Endometrioid, serous, clear cell, dedifferentiated, all those are histological subtypes. How did you reach this diagnosis? Morphology, and wherever IHC was there, you used IHC and came to this diagnosis. But the problem with morphology, as I said in the beginning, even if you put IHC sometimes, there is a lot of subjectivity. There's an inter-observer variability. This can impact clinical judgment and clinical decision-making, which will therefore impact patient treatment. So I'm going to show you cases now, how things have changed, case-wise. And we're going to think like a clinician. We're not going to think just like pathologists behind the microscope. Obviously, that's something to be proud of. But we're going to take part together in decision-making for a patient, okay? Now, then comes the molecular classification. It said, as I said, let's do away with this subjectivity, let's add objectivity. And WHO 2020 recognized this and said, we will now subclassify endometrial carcinomas into molecular subtypes, okay? But we live in India, and the good news is that WHO has an international approach. If you look at the criteria till now in your new blue book, which is more blue and more thicker than the previous blue book, you're going to realize that the diagnostic criteria is still morphology, so HNE, 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 with IHC, so that never goes out of fashion. And I'm going to repeat that in my ovary talk. Basics never went out of fashion, okay? And Madam is here and she will vouch for it. A good pair of eyes, a good brain where you're thinking like your clinician is going to take you very far, okay? And therefore, keeping in mind this international approach, the diagnostic criteria, is still HNE and it's still IHC added because everybody does not have molecular. But we should do our best, and I can tell you, all of you can do your best when it comes to endometrial carcinoma. All right. The good news about molecular classification, I love this. You know why? Nobody has taken my job away because I don't do molecular. As Dr. Shivanshri very nicely mentioned, that we have an intraneural molecular pathology department and a cytogenetics department where some of you have come and visited our hospital earlier. We have different consultants. So nobody took my job and said, now Divya, you're not required, your HNE is not required, I'm going to do the moleculars. No, the good news is that this molecular classification can be replicated by using simple IHCs. So the tick that you see over there, let's come from the copy number high or the P53 mutant group. Just do a P53 IHC. If you do that and you know how to interpret it correctly, you have won the first lot. You can diagnose molecularly your first type of molecular endometrial carcinoma. The MSI high group or the MMR deficient group. You have IHCs, and I believe KGMC has P53 and it's got a very robust 4 MMR markers. So fantastic. You guys are there in the molecular classification of endometrial cancer. But what you have to learn is how to apply it. Okay? And that's what I'm going to show you in the remaining lecture of mine. Now, what is left? What is left in the classification of endometrial carcinoma? Very good. Pole E is left. Does it have an IHC surrogate? Does it have an IHC marker? It doesn't have an IHC marker. So if you are missing out right now in 2023, it's only the pole E. Maybe one center can do it in, UP, where you can send it, and maybe you can get an answer, or you can send it to Delhi, or you can send it to us for the time being, and we can do it for you. But do you really do it for every case? Let's look at that also. We shouldn't just do everything just because the clinician tells us all cancers have to be. So let's look at that also. What can we do in our Indian setup? All right. So let's proceed. Surrogate markers there for MMRD and P53. POLE has no IHC surrogate marker. If you do your POLE mutation, you then got your 3 molecular subtypes. If it's not of those subtypes, what is left? No specific molecular profile if all those 3 are negative. So here you have your molecular classification of endometrial carcinoma. All right. Now, the guidelines say that all endometrial carcinomas, regardless of histology, including carcinosarcomas, should be subjected to molecular testing. By moleculars, I mean you can use IHC surrogates and do the POLE. But how should we do it? Should we just do it up front? सारे कर दो, इतने पैसे हमारे पास नहीं है हमारे पास, किसी के पास नहीं है इतने पैसे. So you have to have an algorithm. Now the algorithm says start with pole E. Do we all have pole E? We don't have pole E. So let's see how we can improve on that. Anyway, guidelines say start with pole E. If pole E is pathogenic, straight away it becomes a polyendometrial carcinoma, endometrial carcinoma. You're done. If it's MMR, then if it's negative, if it's poly non-pathogenic, you do your MMR. How will you do your MMR? Don't do an MSI test. Do your MMR IHC. That's different. MSI is different, MMR is different. I'll be doing that when we do our case. We'll quickly look at frequently asked questions and doubts. So MMR can be done. If your MMR is deficient, which I'm going to show you in a case, it becomes MMRD. And if it's not deficient, you do a P53. If P53 is muted, it becomes P53 mutated subtype. Otherwise, it's P53 wild. And therefore, your tumor is no specific molecular type in the end. Now, why was this sequence chosen? What did I tell you in the beginning? The pole E is called ultra-mutated. Many mutations. Now, while it's having those mutations, lots and lots of ultra-mutations, it can also get an MMR deficient or a P53 deficient as a passenger mutation, just like that. Pehle I am pole E, pehla mutation was pole E. In the course of those mutations, I developed MMR deficiency. In the course, I developed P53. But how will the tumor behave? Tumor will behave like a pole E, irrespective of MMRD, irrespective of P53. So if you want to catch the parent mutation, the first one is pole E. Because MMRD and P53 can happen in those because they are ultra-mutated tumors. Now, what about MMR coming next? Remember I told you, MMR is hyper-mutated. It's got many mutations, though less than a pole E. So, the MMR itself can have a P53 as a passenger mutation and not as the defining mutation. So if you do your MMR, the patient is going to behave as an MMR deficient rather than a P53. Okay? So you do the MMR next. After you've excluded pole E and MMR, you do your P53 IHC. If it is mutated, it will behave as a P53 mutated tumor. So if you follow this scientific sequence, because of this scientific reason, and there is reasoning, you will ultimately get your molecular profiling of your endometrial carcinoma. Is that clear? And this is called something called multiple classifier. I will talk to you about it in detail when we do a case. Okay? Now, what was I talking to you about? Why do we need to detect the pole E mutation? Pole E has the best prognosis. Okay? MMRD has an intermediate prognosis. NSMP also has an intermediate prognosis, and the P53 does worse. Okay, and these tumors are also treated on the basis of their behavior. So that is why, because pole E is ultra mutated and can also carry MMR and P53, you first rule out pole E, and that means it's got a great prognosis. Then you do your MMR, because P53 can be a passenger mutation. You rule out MMR because that has an intermediate prognosis. Then you rule your P53 because it has the worst prognosis, and that you're left with no specific molecular profile. Okay? Now, what are the two most important factors in endometrial carcinoma? Anybody from your head? The surgeon. Okay, the clinician, the medical oncologist, and this was made for a clinical initially, so I put them first. But actually, oh, it went away. Sorry. Yes. The pathologist actually comes first, and I will show you how. The biopsy first comes to you. What is your role as a pathologist in the biopsy? Your role is to give accurate histological type, endometrioid or non-endometrioid. And your role is to grade it. So what used to happen earlier, when I was younger, I used to say, how does it matter? Resection mein karenge. Isn't it? Resection mein karenge, nahi aa raha na, chalo thank God resection hai. Please confirm in the resection specimen. I used to love that line. It keeps me off the hook. I go home at 5 o'clock, isn't it? But should we say कि resection में करेंगे? We cannot. But I used to do that. I'm ashamed. I used to do that when I was not aware. I used to think, इसको नहीं हो रहा ना, let's just do it in the resection. No, I have to try to the best of my ability to subtype and to grade it on the biopsy specimen. Okay? What is my role in the resection specimen? I already know the type. I have to confirm it. I have to make sure the grade is the same. So it could have been endometrioid 2 and it can become 3. So I have to confirm it. I have to do the staging. Less than half of the myometrium, more than half of the myometrium, cervix involved, nodes involved, all that stuff. I have to do that. I have to try to combine the molecular subtype wherever available. I can try with using only 3 markers if I wanted to save money. I would do a P53, MSH6 and a PMS2, because you know that MSH2 and MSH6 works together, MLH1 and PMS2 work. So I want to save money, I'll start with these 3, okay? And of course, if I have the ability to do poly, I will do poly. After all this information, after all the hard work done by the pathologist, the diagnostician, who refuses to accept that they are the clinician, then the clinician comes into the picture and says, okay, risk stratification karte hain, and now we will decide कि इसको क्या treatment करना है. Adjuvant मिलेगा, कि नहीं मिलेगा. अगर adjuvant मिलेगा, is it going to be chemotherapy? Is it going to be radiotherapy? Is it going to be both? But who gave all this information to the clinician? All this. Are there any clinicians in this audience? The room with the doors also closed. It is the pathologist. So they cannot do without you, you know. So they cannot survive without you. Without your information, without your knowledge, they are nobody. Okay? You decided on the type and the grade on the biopsy, then they decide on the type of surgery. I will show you an example. You called it low-grade endometrioid grade 1 on biopsy. They said, okay, hysterectomy with sentinel lymph node biopsy. I'm not going to touch the pelvic para-aortic lymph nodes. I'm not going to touch the omentum. You said serous carcinoma on biopsy. They said, oh, serous carcinoma bola. Okay. I'm going to do a total hysterectomy, pelvic lymphadenectomy, para-aortic lymphadenectomy, and take out the omentum. Final stage, you said T3, N0. They said adjuvant chemotherapy and adjuvant radiotherapy. So who is the most powerful person? It's us. We are the most powerful people. And probably in the meeting in the afternoon, I'm going to say that again, because you cannot treat. So and then of course the question comes of equality. I think everyone's equal, because equal stakeholder, equal investment, equal time. I don't know what equal pay, but I think everything is equal. Okay, so you are very, very important. And this paper over here, ESTRO-ESP guidelines. If you look at the authors, many of them were in the working group. They're pathologists. Because you cannot make any treatment or management guidelines without a pathologist. So please, put it into your head that each one of you is involved in decision making. So staging. You know about staging. This is the FIGO stage. Stage 1A, limited to the myometrium or less than half of the myometrium. Stage 1B, more than half of the myometrium. Stage 2, when it involves the cervix. Stage 3A, when it involves the ovary. 3B, when it involves the vagina. 3C, when it involves the lymph nodes. 4A, when it involves the bladder or the bowel mucosa. And 4B, or metastatic, when it involves the pelvis and it involves the liver, or there are omental disease, etc., outside the pelvis, okay? So, then after all the information that we give our clinician, they do the risk stratification. Low risk, intermediate risk, high, intermediate, and high. So I would suggest whenever you're diagnosing a tumor, because I do gynae in Europe, you have to know the treatment guidelines. Okay, Wolthart's rest in a fallopian tube. Very good to know in first year. I mean, I would want first year, second year, third year to write it in their microscopy. Wolthart's rest is there in the fallopian tube. Now my residents write Wolthart's rest, and I say, oh, very good, she knows it. She's not calling it Brenner or not calling it C, and I delete it. Because, so the fellow comes and asks me, ma'am, you keep deleting Wolthart's rest, mucinous inclusion, cyst. I said, see, I'm very proud that you know it. You have to write it. But I don't need it for treatment, so I take it out. I don't want to confuse my clinician, but whatever is there for treatment has to be there in my report. So it's good you know it, because you have to know the difference between Wolthart's rest and serous carcinoma or peritoneal mesothelial hypoplasia. You need to know that, but that's not important for treatment. So as you grow older, it's like, when you get married, I mean, I'm talking, they're mostly women here. You get married and then you tell your mother every day, आज ये खाया, आज यहाँ गया, आज शॉपिंग पे गया, सास ने डांटा, आज ये बनाया, चाय बनाई. After a year, then you have kids and all. Then मम्मी पूछे कि कुछ तो बता, अब मैं बहुत busy हूँ, time नहीं है. So your information gets lesser and lesser. So pathology is like that, because you realize अब जब कोई important होएगी ना, जब बच्चे को थप्पड़ मारूंगी या someone will misbehave, मैं वो वाला information दूंगी जो important है. Not important information है मम्मी को क्या तंग करना, isn't it? So it's the same story with pathologists. They say क्या अभी क्या clinician को तंग करना, but important information has to be given to the clinician, just like you have to give important information to your mother. Okay, so if you look at these guidelines, low, intermediate, and high, you have your molecular classification unknown. You don't know what that is molecularly, but on the basis of your histology and staging guidelines, you can classify them as low, intermediate, and high. But if your molecular classification is known, it has a correlate, and you can again risk stratify it. And on the basis of the risk, this is the treatment guideline. For example, low risk, whole E, if you go back, stage 1 and 2 is low risk, totally low risk. It needs no adjuvant treatment. Okay, this side is your adjuvant treatment. The minute you say high risk, it means adjuvant chemotherapy and radiotherapy. If you say intermediate or high intermediate risk, only adjuvant brachy chemo may not be added. So on the basis of your information that you give, the treatment is tailored as per the risk stratification. All right? So with this is the introduction to what I was going to say and build up in the subsequent next 6 big cases and 4 short cases. Okay, so Dr. Riddhi asked me, can I get slides? So I said, you know what, I was thinking about it for a couple of days. Should I actually get slides? But then what happens with slides is you need a whole day. I won't be able to discuss the clinical implications. I'll be just showing you morphology, which is great. You have great teachers to show you morphology. But the clinical aspect of it is what I wanted to emphasize on. So with that, we'll start the cases, 6 cases. I will ask you questions. Feel free to just answer. So 55-year-old postmenopausal bleeding in a lady. All our ladies, all of them come with abnormal uterine bleeding. And the sample is either an endometrial curettage or an endometrial biopsy. Okay. So what does the first years feel about this? Is it endometrioid or non-endometrioid? Sorry? Endometrioid. Fabulous. So this is endometrioid. They are looking like endometrial glands because they are oval. Some of them are tortuous. Some of them are a little closely packed. There's an increased gland to stromal ratio. But if you look at their nuclei here, it resembles the endometrial glands. They are oval, they are perpendicular to the base, they have small nucleoli. Nucleoli can be there, isn't it? But they resemble the normal endometrial glands. So, there is some crowding. So, is there a precursor lesion in case 1? So, what are the types of precursors? There's endometrial hyperplasia without atypia, and there is endometrial hyperplasia with atypia, which is called endometrial atypical hyperplasia. There's another name for this, it's called EIN, not EIC, EIN, endometrioid intraepithelial neoplasia. Okay? So, let's go back to this picture. You all agree that these are endometrioid type of glands, but there is an increase in gland to stromal ratio. They have become elongated, they've become tortuous, but there's still some stroma in between them. You agree with that or not? And I just want to keep telling you they resemble this is just the endometrium at the background. Therefore, this is endometrioid, endometrial glands, isn't it? They are like the endometrial glands. But let's look at the nuclear features. What do you think about the nuclear features? Anybody? Are they atypical? Are they very atypical? Is there cytological atypia, or do you think they are okay? It's uniform. Is there variation? Mild to moderate. Now, who decided mild to moderate? Who chose these terms, mild to moderate to severe? There has to be a subjective correlate. Someone just said mild to moderate. I used to love using mild to moderate. Dimag mein aaya, chalo, bol dete hain, mild to moderate. But yes, mild to moderate is a term. But if you see, look at the uniformity. They are all uniform throughout this field. They are all oval. They didn't become round with prominent nucleoli. There are small nucleoli, but they're not very prominent at 10x. Can you see them very prominent? They're not. So there is a atypia. See, it is becoming becoming hyperplastic. Kuch to atypia hoga. But if you start writing the words mild to moderate atypia, it scares the clinician, okay? So choice of words is very important, and subjectivity, you have to get subjectivity into your choice of words. So this is uniform cytology throughout. There is hyperplasia without atypia in this field, okay? Case is not over, picture baki hai, okay? All right. Now, how is the tumor now? How is the area now? Do you feel that the atypia has worsened? It has, isn't it? In other areas, the pseudostratification has increased, but it's still endometrioid, right? It's still endometrioid. So what is endometrial hyperplasia without atypia? There's an increased gland to stromal ratio. They are tubular, branching, cystically dilated glands resembling the proliferative endometrium, but there is a uniform distribution of nuclear features across the subjects, the tissue that you're seeing. It's uniform. It's not changing. Suddenly oval say it's not become round. The nucleoli are not as prominent that they are cherry red or they are very big. They're just there, okay? Always compare with your background normal endometrium, all right? So there's a uniform distribution of nuclear features, and this is endometrial hyperplasia without atypia. The minute you're going to say mild to moderate, it's going to throw the clinician off. Now let's see what's happening to other areas. It's getting a bit more crowded. The stroma is there, but it's becoming lesser, okay? Let's go to higher power. No, it's the same power. A little more crowding. Now you look at the atypia. This is the background for comparison, and this is your current gland, which is showing you atypia. It's become rounded. There are some nucleoli, and you saw the back-to-back. The glands are not getting back-to-back, but they're getting more compact. All right? So, what is endometrial hyperplasia with atypia, also called endometrial atypical hyperplasia? There's a simultaneous change of cytology and architecture. They're getting more crowded, but the cytology is also changing. Nuclei are becoming rounded, more vesicular. You can see through. What do you mean by vesicular, first years? Andar dikhta hai. It's not very coarse. You can see through, and the nucleoli are standing up. How do you want to make this comparison? Look at the background endometrium. I still do it. I go back and forth from my background endometrium before I make a comment on endometrial atypical hyperplasia. So don't use the words mild to moderate just very loosely, just because I don't want to scold it. So let me just write mild. Let me just write focal. These are words which can try to be more specific and more objective. Okay. So what was case 1 till now? You saw areas of atypical hyperplasia, correct? But is it enough? You want to see some more areas. Some more areas over here looked even more complex. There was no stroma in between the glands, complete exclusion of stroma. And in some areas they're almost becoming solid in one half. Can you see that? Again, is this endometrioid? It is. If you look at the type of glands, they are still endometrioid because they are oval nuclei, perpendicular, but they have nucleoli. But in certain places it's becoming to solidify. Okay? So what is endometrioid carcinoma? It's a malignant epithelial neoplasm comprising glandular, papillary, and solid architecture. But remember, they show an endometrioid differentiation. They resemble the normal endometrial glands. Therefore, they are called endometrioid. So they look like this. They may become glandular, they may become papillary, but the glands, the lining cells look like the endometrium. Okay? Now, how will you distinguish endometrial hyperplasia or atypical hyperplasia from endometrial carcinoma? There's no size cutoff. There is no size cutoff. The presence of glandular crowding, endometrial stromal exclusion, significant cribriforming, confluent glandular, labyrinthine, papillary, villoglandular, non-squamous solid growth is endometrial carcinoma. which distinguishes a low-grade endometrial carcinoma from an atypical hyperplasia. Sometimes in a biopsy, you don't know. Now that's a different lecture. How are you? That comes with experience. There's no size cutoff as to what you're going to call atypical hyperplasia, bordering onto low grade, or you'll say cannot be ruled out. There are certain situations where you get pushed into that sort of a situation, depending on the age of the patient. You and the radiology, you're supposed to take a call, which is beyond the scope of today's lecture. We can do that at some other point. Now, this case in certain areas look like this. So what's your diagnosis now? Do you agree with this diagnosis? That is an endometrioid carcinoma in a background of atypical hyperplasia? You agree? What's missing in this? Wonderful. Grade is missing in this. So you need to grade endometrioid carcinomas. And how do you grade them? Grade 1, 2, and 3 on the basis of solid non-glandular non-squamous growth. If you have solid areas which are from less than or equal to 5%, it's FIGO grade 1. If you have solid areas between 6 and 50, it's FIGO grade 2. And if you have solid areas more than 50%, it's called FIGO grade 3. So this, do you agree, is grade 1, lots of glands. But the squamous modules should not be taken as a solid area and you should not count them in your grading. So this is your grade 1 endometrioid carcinoma where there are no solid areas. This is grade 2 where the solid areas are more than 5% but less than 50. And this is grade 3 where this is solid areas are more than 50. But you can see focal gland formation here, here, here. And the cytology mimics the nuclei of your endometrial glands. Therefore, grade 3 endometrioid carcinoma. Is that clear? All right. ISCHIP wants to go a little bit ahead. They say that the microasana growth pattern, where you see small acini like this, should be called under solid. So that's where ISCHIP, the International Society of Gynecopathologists, they want to say that even the microasana, like this area B, if you want to push it to grade 2, don't do that. They are very micro, they're very small in size, the lumen. They try to push this to grade 3 endometrioid carcinoma, and they call this as solid areas. Now we are moving towards a binary grading. Why are we moving towards a binary grading, and why does WHO recommend a binary grading? Anybody? This is what we face all the time. Okay, what is this 5%? 5 to me, 5 to you, 6%. It's troublesome. So grade, if you go back to my introduction, grade 1 and 2 were type 1 in 1983, right? And they behaved well. So kya scratch karna apne head ko? Grade 1, grade 2, someone's fighting, you're scolding a resident. No, it doesn't matter. Whether it's grade 1 or grade 2, or you want to call it grade 1/grade 2 and call it low grade, it's fine. It's all right. But it is the grade 3 endometrioid which you have to recognize correctly on the basis of necrosis or those solid areas, microasana growth pattern, and therefore that is critical. So there has also been a lot of, I won't want to confuse you, but many people say that you should still do grade 1, grade 2, grade 3, particularly for FIGO 2 is important for women in the reproductive age group. So if I say FIGO 2, in the reproductive age group with the myometrial invasion less than half, they may give their patient hormonal therapy. So for that age group, it's important that you try to do a FIGO 1 and scratch your head and say a FIGO 2. But for other women, it's all right. And if you're in doubt, you can say FIGO 1/FIGO 2, put a binary grade, low grade. And if it's FIGO 3, it's high grade, okay? This case, which I was showing you earlier, case 1, 70% glands and 30% solid areas. Therefore, it is, grade 2. And ER was strongly positive. P16 was not block-like. We don't say negative positive in endometrial cancer. Head and neck cancer, you say P16 negative, P16 positive. But I'm not going to talk to you about head and neck. In gynae, it's better to say P16 lack of block or P16 block-like. The reason is, most tumors will show some P16. You won't call that positive. I'll show you some P16 when we do other cases. So P16 lack of block is equal to negative P16. Okay, block means every cell, top to bottom. Okay, is strongly P16 positive. So this case was ER positive. P16 was not block-like, and P53 was wild. I'll show you what wild and mutated as we go along. So this is the final diagnosis. Endometrioid carcinoma, endometrioid, resembling normal endometrial glands. So your 1983 type 1, because it's FIGO2. Bracket, let's add the binary 1, low grade, in a background of atypical hyperplasia. All fits with your type 1 dualistic model. Let's go ahead now. So all these patients are going to have an MRI evaluation. I showed you stages. On MRI, it was T1A. What do you mean by T1A? You need to know these things. Anybody? T1A. Limited to the endometrium or less than half of the myometrium. So the MRI will give you that information. That information the surgeon had, that MRI is less than half. We gave them the information that it is endometrioid, FIGO, and atypical hyperplasia. On the basis of that information, the surgeon decided my surgery will be a simple TAH-BSO with a sentinel lymph node biopsy. The final histology came to us. We confirmed the type, endometrioid carcinoma. We confirmed it. We confirmed the grade. It was a FIGO grade 2, a binary low grade. Remember, we'd done the P53 on the biopsy itself. We didn't repeat it. It was wild. We did the MMR on the resection. It was proficient. LVSI, I'll come to LVSI, was negative. And therefore the final stage was, the PTNM stage was PT1A, N0, bracket, SN, because only the sentinel nodes were taken out. Now, let's go back to this chart. On the basis of this chart, it comes under low risk. Okay? Do you need to do a poly? My question is, I have poly. Do I need to do a poly? Why not? Yeah, ideally we should do moleculars on all, but in this case, do I need to do a poly? Why? It's not going to change the management because this is anyway stage 1A. It's a low risk. Even if this was a stage 1A poly, it will still be a low risk. इसको वैसे भी adjuvant नहीं मिल रहा है, इसको ऐसे भी adjuvant नहीं मिल रहा है. So there's no point in doing a pole E in this particular case. Okay, so a pole. Let's go to the next one. So a pole E mutational analysis was not done because anyways this is a low risk and no adjuvant therapy was therefore planned for this patient. So is this no specific molecular type? I mean molecular profile? Most likely, I mean, I didn't do a poly because in our situation also, though we have all the resources, yet you have to be practical about it. So in this particular stage, poly was not done. This is treated like an NSMP. And now let's say it was stage 2 also. Even if it was stage 2, poly stage 2 is also low risk. You go back, stage 1 and 2 poly are low risk. It doesn't get adjuvant, so you don't have to do a poly. So, what are your low-grade endometrial carcinomas? Only 2. Endometrioid grade 1, endometrioid grade 2, your type 1 of that Bokman's classification. These are your only low-grade tumors. The rest are all high-grade. What grade is this for the residents? What grade is this? This is endometrioid. Number 1, is this endometrioid? Yes, this is endometrioid. What grade is this if this is the only thing that you see? Grade 3, I don't see any, gland formation. Oh, I do see. Here. There's one gland formation here and all the nuclei resemble those of your endometrial glands, isn't it? This is a grade 3. So what are the key morphological features of FIGO grade 3? They should look like endometrioid. Oval or round glands lined by columnar or cuboidal cells, low-grade oval or round nuclei, pseudostratified, some amount of squamous metaplasia, background endometrial hyperplasia. They look solid, but you can see some focal gland formation. They look solid, but some focal gland formation can be seen. Some squamoid areas can be seen. And the cells in the solid look like the cells in the gland, more or less, endometrioid. And very rightly someone said moderate atypia, isn't it? They have moderate kind of atypia, but you don't write that, okay? That's just like Walthar's rest, you know it, but you don't write it because it's going to cause confusion to your surgeon and he'll say, ah, Walthar's rest kya hai? So some information we keep, some information we tell. Okay, so if you wanted to go back and think about it, how much was the atypia? It was moderate. It wasn't screaming at you. Okay, all right. So this is another example of a grade 3 endometrioid carcinoma. You can see some glands in the background and the solid areas with some necrosis on this side. Okay, and they resemble the endometrial lineage. We discussed this earlier, that grade 3 endometrioid carcinoma, if you subjected it, the grade 3 ones, to molecular classification, they are very, very heterogeneous. So 40% of them are MMR deficient, 30% are no specific molecular profile, 18% of the grade 3 can be P53 mutated, and 12% are whole E mutated. So if you wanted to give your money, put your money and say, "Mujhe whole E kisme karna hai," it has to be done in this particular group. And why does this have to be done in this particular group? Again, the same graph showing you the survival and the prognosis, where pole E is the best, MMRD and NSMP are in the middle somewhere, they're intermediate prognosis, and P53 has the worst prognosis. All right. So we finished the grade 3 endometrioid carcinoma, which is your first high-grade endometrial carcinoma. So low-grade endometrial is only 2, endometrioid grade 1 and grade 2. Under high-grade, we just discussed FIGO grade 3 endometrioid carcinoma. Now, how does endometrioid carcinoma behave? The FIGO and the staging is based on myometrial invasion, endocervical stroma, adnexa, lymph node involvement. Just remember, LVSI is a very strict diagnostic criteria, unequivocal. How many of you sometimes say LVSI present, but not sure? How many of us do it? I've done it. Have you done it in the past? That you just say it because it should be there, but you can't really prove it. I think I'm the only sinner in this group. Nobody sins? I have then massively sinned. I used to do it. And I have done it rampantly. Okay? Ki hona chahiye tha, ye nahi hai. Sometimes when there is mess, the lymph nodes mess, you write, see, because it has to be there. You know, how did it reach the damn lymph node? So, wo story alag hai. I mean, that is a different, but that's not sinning. That's just being intelligent. You know, but sinning is when you say, I think so. Is it an artifact? लिख देती हूँ. You know, कोई और बोल देगा. ये QC में जा रहा है. Then you have histopath QC, right? When they take out the mistakes and they say points, LVSI missed, PNI missed. So you say, okay, let me see, must be there. So, but no, in endometrium, LVSI is a part of the treatment guidelines. Okay, so unequivocal. Same or any organ, LVSI, the rules are the same. It should be in an endothelial line space. It should not be a floater. It should conform to the shape of the vessel. It can be attached to the wall of the vessel. It becomes a little more mature. There should be RBCs or something in it. So it should be away from the tumor area. So the rules of LVSI, unequivocal, are the same. And in any organ, the pitfalls are also the same. Carryover, stromal retraction, you know, the rules are the same. But for to use LVSI in a very focal is less than 5 vessels, extensive is more than equal to 5 vessels. And you have to be very sure because it is a part of that risk. When I showed you those tables, it's a part of treatment decisions, okay? You may also have seen that you can sometimes get endometrioid carcinoma in the uterus and you get endometrioid carcinoma in the ovary. Is it synchronous? Is it metastatic? You have to weigh. There is no marker which can differentiate the two. If both the tumors are low grade, if the tumor in the endometrium is less than half of the myometrium, and there is a background of atypical hyperplasia, if there is no other involvement, if there is no LDSI, these are considered as synchronous primaries, and they have a very, very good prognosis. And there are tables and articles and guidelines to assist you to decide whether it's synchronous or one side going to the other. So you have to stage it accordingly. Okay? Case 2, 75-year-old woman had a postmenopausal bleeding. She had a growth in the cervix and there was a cervical biopsy. So what do you think this is? What do you think this is? Quickly, what type of glands? Endometrioid or something else? Cervical, endocervical? You can't say. You're not sure. Okay, you're not. It's from the cervix. How can you be sure? All right, so you're not sure because some of the endocervical adenocarcinomas can look endometrioid. Some of the endometrioid can have mucin and look endocervical. So you're not sure. But you do believe that this is not serous or clear cell or anything, right? This is not squamous cell carcinoma of the cervix also, isn't it? This is adenocarcinoma. Type of glands, they are back to back. We're probably dealing with a carcinoma. Yeah, they're quite endometrioid in appearance. Okay, but you're not sure if this is an endometrioid type of cervix. Is it important to distinguish endocervical adenocarcinoma from endometrioid adenocarcinoma of the endometrium? Yeah, because the treatments are different. For cervix, you give chemoradiation. For endometrium, you do a staging surgery, isn't it? Unless it's metastatic. So the treatment protocols, the type of surgery, even the type of surgery is different. You do a THBSO for endometrial cancer, for a cervical cancer, you do a more radical one. You take out the vaginal cuff. Sometimes more than stage 2, etc., you give chemorads for cervix. Here, no. In stage 3 also, you'll do a surgery. So very, very critical for gynecopathologists is to be able to distinguish an endometrial primary from an endocervical primary. Okay? So these tumor cells were strongly and diffusely positive for PAX8. You all have PAX8. PAX8 tells you it is of Mullerian origin. Endometrial cancers are mostly, always, not always, 95% and more positive for PAX8. Endocervical can be negative, remember that, for PAX8. They can be positive or negative. Endometrial cancers are strongly positive for Vimentin. Endometrial cancers. Endocervical are negative for Vimentin. Endometrioid of the endometrial are ER and PR positive. ER can sometimes come, I've seen that many times, but PR is a very good discriminator. PR is negative. So this case was PAX8 positive. It was Vimentin positive, ER and PR positive. These tumor cells were negative for P40. They were negative for CEA. Endocervical cancers are CEA positive. C for cervix, C for CEA. There was no P16 block light. What does it mean? Why did I do a P16 here? It's not looking serious. For HPV, so it's now P16 has two roles. It is a tumor suppressor marker and also it is a surrogate for HPV testing. In this situation, P16 was done to rule out a cervical origin. So P16 was, I won't say negative, was lack of block positivity. P53 was again of the wild type. Cervix biopsy signed out as, I'll show you some pictures, not of this case, but some relevant pictures. The cervix biopsy was signed out as involved by endometrial carcinoma, FIGO grade /1 to 2, bracket low grade, okay? Now, this is your endometrioid carcinoma. This is the P16. Do you see areas of positivity in this? You do, right? You want to call this positive? No. This is lack of block positivity. We don't say positive, negative. We say, it's better to say lack of block positivity. ER and PR are diffusely positive. You use similar, like how you use in the breast. You can say the percentage of cells and the intensity. I don't put in all red. I just give a descriptive. Do you put all red for ERPR in the, not here? Yeah, only in breast. So we just give a descriptive so that the clinician knows 80% tumor cells show strong nuclear positivity or more than 95 or strongly and diffusely positive for ER and PR. We give a descriptive thing. And for P16, there's lack of block positivity. Yeah, they can. So that's what I'm saying. You'll never, not never, most of the time you're going to get this patchy expression. That is not block positivity. So be very careful as to what you are, Another thing, so this is almost the north of India. So Rajma in every North Indian house is different, na? So Rajma होता है, but सबके घरों में अलग-अलग बनता है, taste हर जगह का अच्छा होता है. So P16, however, is a very standardized thing. Everywhere, it's not like Rajma. It should look, a positive should look block-like. It cannot look kahin pe aise, kahin pe aise. There's a standard thing, it should show block positivity, okay? So you have to be these are very robust stains, P53, P16. They cannot be like, I always say they cannot be like Rajma. That it can be a little bit, thoda mera ER alag hai. No, it can't be. Your P16 and P53 should behave very well. Because on that basis, you're calling it block positive or mutated P53. So I'll come to P53 in a bit. So your ER and PR was strongly positive. This is an endometrial endometrioid carcinoma. Is that clear? Now, if this was the cervix, see, this is another case. This is not this case. A cervical adenocarcinoma, which has got some mucin on the top, but many endometrioid-looking areas. Cervical adenocarcinomas morphologically have some mucin and they have this basal apoptosis and floating mitosis in the mucin. But sometimes the mucin can be so less that they look like endometrioid tumors. And this is the block positivity of P16 I was talking to you about. There's no area practically left. So in squamous, we say from top to bottom and like this, but this is not squamous, we're talking about a gland. That P16 we'll talk later, I'm not talking about cervix right now. This is block positive, practically every cell, strong nuclear cytoplasmic positivity. And this is the HPV-ish, which is showing positivity. And ER is negative. What you can see positive is your internal stroma, which is positive. Your PR is also negative in the cervical adenocarcinoma. What you can see positive is in your stroma. So you know that your test has worked if your internal control has worked, okay? All right. And this is a table just to tell you that you need clinical information, you need microscopy, and you need immunohistochemistry. I love this table to compare endometrioid carcinoma from endocervical adenocarcinoma. So in endometrioid, bulk of the tumors in the endometrium or in the lower uterine cervix. There is an EIN or an atypical hyperplasia in the background. Squamous morules, tall columnar cells can be there. There may be foamy histiocytes. Endometrioid endometrial cancer is ERPR positive, P16 lack of block, Vimentin positive, CEA negative. Vis-a-vis the endocervical adenocarcinomas, bulk is in the cervix. It can also be in the cervix going to the lower uterine segment. It can be a tricky site. There's a barrel-shaped cervix. There's a precursor, AIS, adenocarcinoma in situ. They have mucin, goblet cells, and I spoke to you about floating mitosis in the mucin and basal apoptosis in the base. This is the right opposite of endometrioid, endometrial. They are ER and PR negative. P16 is diffuse, strong, block-like. Vimentin is negative, CEA is positive. Are these rules followed? Absolutely not always, but you have to take into account as much as possible. You can also use MMR staining. I didn't add it over here to help distinguish endometrioid adenocarcinoma from an endocervical. Because if you've noticed, many of the endometrioids, if you go back, were MMR deficient. If you get MMR deficiency, it's 100% not endocervical. So I use it in my practice very often. When I use an MMR, I see when I'm stuck and I'm seeing there's an overlap or something, and the surgery is going to change. And if MMR deficient it can come, you know this is endometrioid and not from the endometrium and not endocervical. Okay, so let's go back to the case. This case was involving the cervix and the MRI was ordered. There was a tumor in the fundus extending to the cervix. Because we called it endometrium, they staged it like the endometrium T2. Remember, cervix is T2. Now, with this information, the patient, it's FIGO2, I think, patient, because it was T2, the surgery changed. Because it was involving the cervix, the patient underwent a radical hysterectomy with a vaginal cuff was taken, bilateral pelvic lymph node, para-aortic, and an omental biopsy was taken. This showed a peculiar pattern of invasion, which I will show you, called the MELF pattern of invasion. There was extensive LVSI in more than 5 vessels, real LVSI, not that something I was cooking up. MMR was proficient on the resection. P53 was wild on the biopsy. I staged it as N2, there was micromets in it. This was the stage. Now let's look at the MELF. MELF is the microcystic, elongated, fragmented type of an invasion. On higher power, they look like a small cysts, with an elongated, and these glands look fragmented in between them. And they are surrounded by these lymphocytes. It's a very peculiar type of pattern of invasion. Wherever you see a lot of lymphocytes and around a vessel, you should try to look at MELF pattern. This MELF pattern is associated with LVSI. Okay, that's where you have to start looking. And this is seen in low-grade endometrial carcinomas. Many of the low grades have this sort of a look. And this is a lot of attention was being given to MELF. And this is a recent paper where they're trying to see whether it is an independent prognostic factor. Unfortunately, it is not. They've not found it to be an independent prognostic factor, but I do use it to pick up areas of LVSI. Okay, it's a very good pointer towards LVSI. This tumor was indeed involving the cervix. As you can see, there's a bit of squamous mucosa. This was totally going into the cervix. It's a PT2. And this was also involving the lymph nodes, and the size of this mets was as that of a micromet. It wasn't more than that. And on the basis of this information, PT2, N2, para-aortic micromets, this was a high intermediate grade risk. And therefore, it was also a MMRD, or because this was a high intermediate risk. Sorry, it was a high risk. Oh, this is a stage 3. It is a high risk, and therefore, this patient, a Pol E mutation analysis was not done in this case. Why was it not done? Anybody? Because anyways, this requires adjuvant therapy. Because it's stage 3, it involves the lymph nodes, and therefore, in this case, Pol E was not done, and adjuvant therapy was given. Now, case 3, I'll go faster. 65-year-old postmenopausal bleeding. Endometrial aspiration biopsy. What is the structure that you see here for the postgraduates? On low power, what can you see? Yes, H and bolo. Cystic spaces, lot of hemorrhage. What's the shape of this tissue? It's got glands lining on all sides. Very good. It's a polyp, okay? And if you see, it's got a stroma, it's got blood vessels, cystically dilated spaces. But somewhere here, can you see the polyp has become very blue? And you want to focus on that area. Now that area looks like this in the polyp. Looks like this in the polyp. Does it resemble endometrial gland? Does it resemble a normal endometrial gland? How many say it resembles a normal endometrial gland? Anybody? Does it resemble a normal endometrial gland? Here, does it resemble a normal endometrial gland? So it's non-endometrioid. So what do you think this is? It's looking very pleomorphic at this power itself. It's got prominent nucleoli, cherry-like nucleoli, very prominent, not small and basophilic, eosinophilic, red cherry-like. It's got areas of mitosis. Look at this. How ugly can it get? So this is a non-endometrioid serous carcinoma arising in a background of an endometrial polyp. Does it resemble normal endometrial glands? All the time ask yourself that question. It doesn't. Okay. This is P16 block positivity. Okay, and is this because of HPV? I just told you it's a surrogate marker for HPV, but in serous carcinoma, is it because of HPV? What is the pathway? Tumor suppressor? Okay, so that is the path, not the HPV pathway, and this is block positivity. Why is this not block positive? This other areas, your glands, why are they not block positive? Your background glands? Because they're normal, isn't it? Only your tumor is P16 block, diffuse strong nuclear and cytoplasmic positivity. What about your P53? Is there staining in the P53? HPV will give you the same kind, yes, same block positivity. In the context of serous carcinoma, it is not by the HPV route or the HPV pathway, this is by the tumor suppressor pathway when it comes to the serous carcinomas. Okay, we are not doing it for HPV in serous. Right? What is the P53 staining? Any one answer? Wild type, okay. Why do you call it wild type? There is some nuclear positivity. Unfortunately, there isn't much nuclear positivity. Your internal control, which is the stroma, is positive, okay? Whereas your glands in the middle are negative. So what kind of staining it is? Null type of staining. So this is a P53 mutated, but the null type. This is what stain? WT1. And WT1 is positive or negative in this? Your stroma is showing positive, your internal control has worked, but your tumor is negative. Why did I do it? Just to show you that endometrial serous carcinomas are generally WT1 negative or focal positive, but your ovarian serous, which we'll be doing in the afternoon, are strong diffuse or null type, are strong diffuse WT1 positive. So PR is patchy positivity. So this is an endometrial serous carcinoma. It usually develops in the background of atrophy or a polyp. You see focal areas of papillae, budding, exfoliation, slit-like spaces, some samoma bodies, not much. I see them mostly in the context of low-grade serous in the ovary. High-grade serous where you don't see that much of samoma bodies. Nuclei are really very pleomorphic. So for you over there, severe pleomorphism, which can be identified objectively. Variation in size, some are small, some are big, really ugly, vesicular, prominent nucleoli, cherry-like, not basophilic. It's not that endometrioid don't have nuclei. All of them have prominent nuclei. But really prominent macronucleoli looking red and cherry-like is seen in serous carcinomas, not in endometrioid carcinomas. Pleomorphic, bizarre forms, severe mitosis, a lot of mitosis and necrosis. These are key morphological features of endometrial serous carcinoma. So we finished the second type of high-grade endometrial carcinoma, which is your serous carcinoma. And all of you know that invariably have the P53 mutation, and some of them, that is 1/3, also show HER2 amplification, and that's why they should be done, because in the recurrent cases you can treat them with trastuzumab. Okay, and if you map your serous carcinoma to the molecular, I showed you in the beginning the bold line, most of them or all of them are the copy number high or the P53 mutant type. Okay, and this is an excellent paper which tells you about the P53 staining patterns. If you have an absent P53, you'll have a wild type of staining. I'll show you a picture. For a P53 mutation, there are 4 common types, or the 4 common phenotypes. Strong diffuse staining in every cell, practically every cell, more than 80% is a P53 mutated. Complete absence or much lesser, sometimes you can see a blush when your internal control, is the null type. There is another type called the diffuse cytoplasmic staining. That's your 3rd type. And very rarely, it is looking serous, but it's showing you wild, because probably that there is a truncated mutation. Very rarely you can see, I have hardly seen, maybe less than 5% of my cases, where they show a wild type, but they're looking serous completely. This must be a truncated mutation not expressing at the protein level. So there are two major types of P53 phenotype. The strong diffuse, so this is your wild type where there is some staining and some are heterogeneous staining. This is your mutated overexpressed type. This is your null type where there is no staining in the glands and deep staining in the stroma. And this is your cytoplasmic type, which should not be missed or forgotten. This is an aberrant type. You should keep that in mind. I'll just take a little break. Okay. Now, the prognosis of endometrial serous carcinoma, it's really poor. A correct diagnosis is vital because they're all clinically aggressive and they are responsible for 40% deaths of endometrial carcinoma. With the rare exception of serous carcinomas limited to the endometrium or limited to a polyp, they carry a very high risk of recurrence regardless of stage and regardless of the LVSI. And because of this aggressive nature, the minute you say serous carcinoma, unless it's limited to the endometrium, you give it adjuvant radiotherapy and chemotherapy. Because 1/3 of the cases show HER2 amplification, in the recurrent stages, you can also treat it with trastuzumab. So this particular case was P16 block positive, P53 was mutated null type, MMR was proficient. Why did I do an MMR in this case? Why was an MMR done? Anybody? I told you if a tumor comes out like this sort of a tumor, which it won't, see, it had a serous morphology, but sometimes you can get an ambiguous high-grade looking tumor if it is MMR proficient. P53 is a passenger mutation and it should be treated like a MMR deficient tumor. Also, a poly was done on this particular case, which was of the wild type. HER2 was negative. The final diagnosis was endometrial serous carcinoma or a P53 abnormal endometrial carcinoma, LVSI negative, stage 1B, N0s, and one second. And according to the risk stratification, it comes in the high risk. And you want to make sure it's not a pole E, because if it's a pole E, it will get shifted, it is stage 1B, it will get shifted to low risk. So a pole E was done in this particular case. And this was a high risk and adjuvant therapy was planned because pole E was of the wild type. Case 4, 48-year-old female, postmenopausal bleeding, endometrial curettage. What is this diagnosis? Wonderful. It's such a pretty tumor. It's a morphological diagnosis. You do IHC for this? Yes, if you have an abscess and a Lipicam-3 and an ERPR, you may throw it in. But it is a pleomorphic tumor, but not as pleomorphic as a serous carcinoma. In fact, it doesn't even show much of mitosis. Does it look like an endometrioid to you by any chance? It doesn't look like. It's got these tubulopapillary structures. The papillae have hyalinized cores. It's got prominent hobnailing, clear cytoplasm, some have eosinophilic cytoplasm. It's a very pretty tumor, unlike a serous carcinoma, which is a very ugly tumor. Here you can see the hobnailing as well as the clear cytoplasm. Does it look like your endometrial glands? Please remember, therefore they are non-endometrioid. It's not looking an endometrioid gland. This is your typical hobnailing where the nucleus projects out like a hobnail of a shoe. This is another pretty picture to show you these cores. See, even serous carcinomas have papillae, isn't it? Look at the papillae of the clear cell carcinoma. It has got these hyaline pink material in the papillae. These are very typical of a clear cell carcinoma. Look at the hobnailing of the cells. Look at the monotony in the pleomorphism. It is pleomorphic, but in a very monotonous or a boring way. It's not as horribly pleomorphic like a serous carcinoma, and it also has less mitosis. Another picture to show you the hyaline globules and the clear cytoplasm. In this picture, it's predominantly tubular. It's napsin A positive, ERPR are negative, P16, look at the staining, it's lack of block. I won't say it is block, there's lack of block. We all agree there is some expression, but it's not block positive. P53, what do you think of the P53? It is showing some heterogeneous weak staining, and in the nucleus it is of the wild type. So this was your third type of high-grade endometrial cancer, which is your clear cell carcinoma. Now, remember the times when we used to find endometrioid carcinoma with clear cells and we say some areas of clear cells seen. The minute you say that in your biopsy, the patient will go in for total hysterectomy, pelvic, para-aortic, omentum will be out. The minute you say that in your biopsies, I used to do that, focal areas of clear cell change seen. What does that mean? It means nothing. It means that some of the end, this is an endometrioid adenocarcinoma with secretory change, is showing some clear cell. It can even show some hobnailing sometimes, but you have to be sure with morphology, show it to a colleague, apply immunohistochemistry, and make sure there are no high-grade areas, or it's not a mixed carcinoma, and then please swallow that word clear cell in your report because it's going to change the surgery for the patient, okay? So to this side is your typical clear cell carcinoma, and this is some endometrioid adenocarcinoma with some clear cells. Here is a clear cell on this side with the hobnailing. It is pleomorphic, but not as pleomorphic as this, because here there is hobnailing on the other side, but it's very, very pleomorphic. So one is a clear cell, the other is a serous. Does it make a difference if you call it clear cell versus serous in your biopsy? Not really, both are high grade. If you're in doubt, it's okay. No, it's not a crime if you call something mixed with some serous, because as far as you know how to distinguish your low grade and high grade, more or less it should be okay. So the clear cell carcinomas are napsin A positive. I do napsin in my lab. I do ER and PR. They're ER and PR negative. Sometimes you get ER, but PR is generally negative. I do get some ER expression, but PR is negative. I don't have HNF1 beta, which is usually positive in these tumors. The reason is from the experience of my other colleagues in TMH Mumbai and with other international colleagues, they also have not found it to be a great marker. So I never got it. It's more of a morphological diagnosis. As you, I put it clear cell, you all said clear cell unanimously. So it's got a great histological correlate. So I'm not really keen on getting HNF1 beta. They are generally P53 wild. P16 shows lack of block positivity. ER can be negative. It can also be a little weak. Some focal expression that does not really rule out a clear cell. And PR, as a rule, is generally negative. And this is a table which I think can be really used to distinguish all the three types, all the four types, major types of endometrial carcinoma by the aid of immunohistochemistry. I have discussed it with your seniors. You have all these markers. Use them judiciously. Don't overuse them. Use them judiciously. And suppose you're not seeing any clear cell area. If you throw in a napsin, there'll be some area which will show positive. So don't do it if you're not seeing those components, just for the heck of it. If you feel morphologically you have a serious doubt, only then put it. So endometrioid carcinomas grade 1 and 2 are ER-PR positive. They lack block positivity for P16. They are P53 wild. And they are napsin HNF1 beta. Racemase, by racemase I mean amacal. They are negative for these markers. But don't put it in. If you put it, some amount of focal staining will come. On the basis of that, don't call it mixed carcinoma. Endometrioid grade 3. It's a different tumor. It's a high, don't say it in the same breath as you say grade 1 and grade 2. It's a high grade endometrial carcinoma. They are ER and PR positive. They also lack block positivity for P16. P53, as I told you, is a very heterogeneous tumor. Grade 3 can be a poly also, grade 3 can be P53 mutated also, grade 3 can be P53 wild also. So it's a very heterogeneous tumor. Serous cancers can be ER-PR positive, negative. They show strong block positivity for P16 and P53 is mutated. What are the mutated types, phenotypes? Strong diffuse overexpression, null type, cytoplasmic, and very rarely, it is really looking serious, but your P53 comes wild, the reason is a truncated mutation. But that should be really rare. You should show it to your colleagues before you come to that conclusion. Clear cell carcinoma, remember ER can be there, weak, focal. Don't rule it out just because you got some ER. PR is generally negative. Your internal control in the stroma works very well. P16 generally lack of block positivity. I have seen some with block positive P16 also. Then I had to go down the endocervical route as well and to rule out. P53 is again, it can be mutated as well because clear cell is again a heterogeneous tumor and it can be any of the subtypes as I showed you earlier. But if you really on a true morphologically looking clear cell, you put napsin, HNF1 beta, amacal, glypican comes out very well. It's positive for that. So as I said, clear cell carcinoma more molecularly is very can be NSMP, can be MMRD, can be POL-E, can be P53 abnormal also. And the prognosis of therefore clear cell will depend on what it is molecularly. If it's P53 abnormal, it will behave very badly. If it is POL-E, it's going to behave very well. So ultimately, we are transitioning from molecular to from morphology to molecular because the prognosis and the end result depends on the. So I discussed that. This patient was on MRI, more than half of the myometrium. We had called it clear cell. So the patient underwent TAH, BSO, pelvic, para-aortic, limb dissection and omentectomy. पूरा मतलब अच्छे से staging surgery हो गई. P53 was wild on biopsy. MMR was proficient on resection. The POL-E was wild on resection. It was called a clear cell carcinoma NSMP because if it was POL-E, it will not get adjuvant because it can be anything, right? And that's why a POL-E was done. But LBSI was negative, PT1B clear cell. If you see PT1B clear cell, which is not POL-E, is a high risk and therefore it needs adjuvant therapy. So we have to think like the clinician and therefore give our final diagnosis. Case 5, 71-year-old female postmenopausal bleeding. This was a little funny, different case. In this, the hysterectomy came to us from an outside center for review, which happens. A person has already got hysterectomy at an outside center and has got the slides and blocks for review. They had called it endometrioid grade 2 and they had submitted the blocks for review. So this was the low part and this is the high part. Is it endometrioid in nature? They are not. They are a little tall, columnar, a little more pinkish, but oval nuclei. They're not round like a serous. What do you think? Little endometrioid? I agree, a little bit endometrioid. Or endocervical, yeah, I didn't see floating mitosis, I didn't see basal apoptosis. So now do you feel it's endometrioid, maybe a little fine papillae? What do you think of the nature? They're not very pleomorphic like serous. The pleomorphism is not, it's not changing, it's more or less uniform everywhere. Now, what do you think? Anybody? Can you see a lot of lymphocytes in it? That you can see, right? Intratumoral, peritumoral lymphocytes. But what do you think of the morphology? Little more pink. It's got a little more voluminous cytoplasm, but the nuclei are more or less uniform, like oval with small nucleoli, like an endometrioid. So do you agree? If you're in doubt, so anyway, an BMS2 and an MLH1 was done. They were lost. MSH2 and MSH6 was intact. So can this be serous? Can this be serous? Unlikely. With this morphology also, but it's MMR deficient. So MMR deficient tumors are not serous. You remember they're all P53 mutated. Anyway, this was ER strong positive. P16 showed lack of block positivity. So cervix is ruled out. ER strong positive. P16 lack of block positivity. Cervix was a question. Yeah, it had voluminous cytoplasm. It's a good question. So it's ruled out. P53 was wild. So it's not serous. Okay. MMR was deficient. So most likely endometrioid in morphology. But a POL-E was done. It was wild. So the final diagnosis was an MMR deficient endometrioid carcinoma, FIGO grade 2, low grade, LBSI negative, invading more than half, so PT1B, no nodes involved, N0, stage 1B. Now this falls under the intermediate risk. It is not a poly, so it's not a low risk. Now, because it's stage 1B intermediate risk, only ball brachytherapy was planned and therefore no chemotherapy. So you need to know your histological typing and your molecular typing in many situations if you want to correctly treat the patient. Okay? Should we do MMR IHC on all cases? What do you think? Now, after so much, we should. So universal testing of MMR is done in all endometrial cases. The reason is it's diagnostic, number one. It is considered to be a marker of endometrioid morphology. You get MMR, it's most likely an endometrioid morphology. You get MMR, it can't be endocervical. Remember I told you I use it for endometrial endocervical, so it can't be endocervical. It can be used for pre-screening because you identify patients with Lynch syndrome. So it should be done. It's of prognostic significance because I told you MMRD is got intermediate prognosis. And it's got treatment implications because if you're an MMR deficient tumor, you have the potential to treat it with immune checkpoint inhibitor therapy. So it should be done in all cases. It's a very, very useful test, and I'm so glad that at KGMU you do it, which is great. Now, should you do 4 markers? Should you do 2 markers? I think it's perfect to do 2 markers. You know, you can do a PMS2 and an MSH6, but if this is abnormal, you need to do the MLH1 and MSH2. And CAP protocol should always be there on. All of you have smartphones, tabs, a computer screen in front of you. If not, you have your tabs in front of you. So just open that, access how you interpret it, give it in an interpretation. That loss of PMS to MLH1 can be because of hypermethylation, it can be because of a somatic event. Rule this out before you do testing for Lynch syndrome. So I think it's great, and MMR should be done in all cases. If you have loss of MMR, does it mean you've identified Lynch syndrome? What's the answer? No. As I told you, it could be because of somatic events. It could be because of hypermethylation. So you have to rule all that out before you call it Lynch syndrome. Should you do MSI testing or should you do MMR IHC? Preferably both, okay. But
MMR would be preferred or
yeah.
You have to do one, you do MMR.
You do an MMR, correct. And if you're doing one, you don't need to do the other one also, because MSI is a laborious test. You need more training. You require non-neoplastic tissue. It's more expensive. Again, it won't tell you about the gene affected. So rather you do an MMR. We all have very robust IHC labs. So this is great. And you can do it to start with 2 markers. So with that, I go to case 6, which is the last of my long case, 61-year-old postmenopausal bleeding. This also had undergone a THBSO bilateral pelvic para-aortic lymph node dissection in a fairly good cancer center in February 22. Now we're in 23, okay? And it was called endometrioid grade 2, and the slides and blocks were submitted for review. So do you agree that here it looks endometrioid? Do you agree? So this is one area, it looks endometrioid. Now, another area. So over here you feel it's grade 3 horari. Solid area is horari, isn't it? Grade 3 horari. What's happening here? Some clear, then what else? Some lymphocytes looking more pink. You agree, more pink now? Now? What's happening? Squamoid, tumor giant cells, intratumoral neutrophils, some peritumoral lymphocytes, bizarre nuclei. So what did I see till now? One area was looking endometrioid. One area started looking solid. One area started looking high grade like serous. I don't know when to put my marker. I really don't know कौन से slide में करूँ, combine करूँ. कभी-कभी होता है ना, इसको combine कर देते हैं. Let's do these 2 areas. Let's see. I don't know. I see peritumoral lymphocytes, intratumoral. They have an ambiguous histology. I can't put my finger and say exactly what. Not looking like carcinosarcoma, not looking like dedifferentiated cancer. I don't know what this is. Mixed cancer. Yeah, it can look mixed. It can be mixed, high-grade serous and an endometrioid. Yeah. Now I need to see what it is. It's ambiguous. Again, look, some areas are looking squamoid, risk mitosis in some, typical endometrioid in the others. Some more areas showing peritumoral and intratumoral lymphocytes. And some areas again looking solid. So let's look at the markers. Usually positive for ER. So feels like it could be endometrioid in the endometrioid areas. P53 wild. Even those high-grade areas were P53 wild. P16, just look at the P16. This is your internal control. Look at the amount of expression, but this is lack of block positivity. This is not block positive. Your MMR, what is it going to be? What is this MMR pattern called? Proficient. So we don't say positive, negative for MMR. We say proficient and deficient. Tumor, all MLH1, PMS2, MSH2, MSH6, all were retained. The tumor nuclei were retained. So what were the key histological features in this case? So prominent tumor infiltrating lymphocytes, peritumoral lymphocytes, intratumoral heterogeneity, mixed type of morphology, ambiguous, patchy bizarre atypia, tumor giant cells. Do you agree? Now, I don't have polling. It's February 2022. What are you going to call this tumor without polling? Chalo, I can't type it. I'm not able to type it. What do you want to tell your clinician now? Low grade, high grade? इतना तो बोल सकते ना. I'm not able. P53 wild है. I can't call it serous. Endometrioid but ER positive है. P53 wild है. MMR proficient है. P16 lack of block है. So grade 3 endometrioid maybe. I can do that, right? So I don't have poly. I'm going to say endometrioid carcinoma, not FIGO2. I mean, it's FIGO bizarre nuclei. So FIGO grade 3. Tumor invades more than half of the myometrial thickness. Cervical stroma is involved. Not just the overlying epithelium, the stroma is involved. Ovaries, fallopian tubes free. All lymph nodes, pelvic, para-aortic, negative for metastasis. PT2, N0. High grade. Now, on the basis of this, but I don't have poly. High grade, high intermediate grade, I don't have poly. MMR proficient, P53 wild. Chemotherapy. So this was planned for 4 cycles of platinum-based chemotherapy. Now, this I told you is February 22. I noted this case down because we are all armed with the information that grade 3 endometrioid is a very heterogeneous tumor and it can be all over, and agar poly karna hai to is pe karo, isn't it? So anyway, patient got chemo 1, chemo 2, chemo 3, and by May he was ready for the 4th chemo. By this time I was validating my poly, and the first case I took out, it's a recent case, was this case because I had noted it down. This is ambiguous. So my colleague who showed me this case ko kaise bolu? I said, you call it ambiguous. So he wasn't very confident and said, I said, you call it high grade with ambiguous. I want to say it's endometrial. So but he said, but madam, ER hai na, P16 nahi hai, MMR proficient hai. I said, okay, then call it grade 3, but write the word morphologically. And this is the one, this pe poly karenge, amongst the other cases that we had taken out. So the first case that I did a poly on was this case in April 22, and it was showing a poly. So it was actually 4 cases I had taken out. Out of this came out positive. So everybody thought, oh my God. I said, no, it's a bias because I have taken it out and I want to validate, and I knew this will be positive. So this showed the mutation. It was positive for the heterozygous missense variant at exon 9. So it became a stage 2. It was involving the cervix, remember, but a POL-E mutated tumor. From high intermediate risk, it moves to low risk. But what to do? He's got 3 cycles of chemo already. But I called up the clinician and we validated. Even at PMH Mumbai at that time was also validating it. And we had a discussion, we had an MDT, and that's where you're equal to your clinician, where you call them up and say, I know that I do, take it up for MDT. And it's not only that the surgeons bring their cases or the medical oncologists, the radiation oncologists bring their cases, we also bring our cases to the MDT. So this was called POL-E ultra-mutated endometrial carcinoma. It's not serous, it's not grade 3, it's got a very, very favorable clinical outcome. C4 or the 4th cycle was not given. radiotherapy was deferred. And don't you feel nice when it's the first case that you put in for validation and that comes out positive? So since then, I'm going to share our POLE experience. What is POLE? It's the mutation has to be a pathogenic mutation, which are only certain ones. It can't be the non-pathogenic one. It should involve the exonuclease domain, and it should correlate with this ultra-mutated phenotype that I just discussed with you. So there are 11 pathogenic mutations. This is from Dr. Poon's, one of his slides. That acknowledgement somehow went. This is his slide actually. This is 11 pathogenic mutations. Ours was this one. All of them are found in exons 9, 11, 13, 14. This is an excellent paper for the interpretation of somatic POLE in endometrial carcinoma. You can refer to this. Functional mutations occur in the exonuclease domain, but not all are the ones in the exonuclease domain are functional. Sometimes there are very rarely some mutations outside the exonuclease domain which are functional. Remember, the non-functional ones should not be considered as POLE. And so for now, there is this list of 11 mutations. If it falls under this, it's pathogenic and you can call it POLE ultra-mutated. And if you're stage 1, stage 2 POLE, no adjuvant therapy, excellent prognosis. So what are the molecular diagnostic tests available for POLE? NGS, Sanger, hotspot single nucleotide snapshot assay, and droplet digital PCR. The methodology used in CMC is the Sanger sequencing, hotspot mutation analysis. There is no IHC correlate, and there won't be for POLE mutations. Okay. Now, why do they have an excellent prognosis? Because I told you these are ultra-mutated tumors. They have a very high tumor mutational burden. They have a high neoantigen load. They're very immunogenic. They are associated with increased tumor lymphocytes, peritumoral lymphocytes, PD-L1, PD-1 expression. And this enhanced T-cell anti-tumor response plays a very important role in this favorable prognosis. I spoke to this initially because I didn't want to suddenly introduce heavy terms, but there's something called the multiple classifier, which I did allude to in the beginning. 3 to 5% of endometrial carcinomas have more than one mutation. I discussed. If you have P53 in the presence of POLE or P53 in the presence of MMR, P53 is acquired mutation. It's not the driver mutation. It's a secondary mutation. So if you have POLE and also P53, your tumor should be classified as POLE mutated. If you have MMR deficient and P53, your tumor should be classified as MMRD. If you have pathogenic POLE and MMR, your tumor should be called POLE mutated and not MMR deficient. If you have non-pathogenic POLE and MMR, non-pathogenic POLE should not be called POLE. The tumor should be classified as MMR. So the authority is POLE over MMRD over P53. And if it is none of these, no specific molecular profile. Is that clear? Any questions? Okay. So I told you about what we do in our hospital because we can't do POLE on everything, isn't it? And you shouldn't be doing. Now, the British Association of Gynecopathologists, we had a meeting in February this year in Tata Medical Center. Dr. Riddhi had come and it was a great meeting, not because we held it, but because it was truly it was an exchange of ideas between the US, UK, Belgium, Canada, Dr. Navina Singh, so many other countries, Denmark and Singapore. And then it was all over the country. Everyone came, north, south, east, west. It had a great, great representation. But I feel that the British Association of Gynecopathologists, they have identified the algorithm really well. It suits the Indian setup also. This is the algorithm which is freely available on the internet. But let's break it up. Do the biopsy. And on the biopsy, do MMR, P53 and ER on all cases. This should be the basic. MMR should be done on the biopsy, P53 on the biopsy, ER on the biopsy. Then you do your surgical staging the patient goes for. where you do the type, grade, stage, and you do your LBSI and all that. In group 1, if your MMR is abnormal and P53 is abnormal, that's your group 1. Group 2 is your low grade G1, G2, endometrioid, low stage, no or focal LBSI, ER positive. Group 3 is non-endometrioid 1A with no or focal LBSI, or endometrioid with any of the following: ER negative, stage 1A with substantial LBSI, stage 1B or 2, and your group 3 is stage 3 and stage 4. Now, which groups need Pol E? In group 1, Pol E NGS testing recommended, because Pol E is the driver mutation. If you find out Pol E, you'll know your MMR and your P53 are secondary. That's why it's important. And in group 3, Pol E NGS testing is recommended. Now, group 2 is anyways low grade, anyways low risk. You don't need to do a Pol E as we've done with our other cases. And group 4 is anyways high risk, which needs adjuvant therapy. You need less your MD wants to do it for Pol E. You have to give it adjuvant. But if your NDT wants to see how the tumor will behave, then only you may do a Pol E. So Pol E should be done in group 1 and group 3 in our Indian setting, I feel, and group 2 not required, group 4 not required. Okay? So this is the experience of Pol E testing at TMCK, where we've been doing it for the last 6 to 8 months, total of 40 cases, or no, 50 plus cases, and we've got pathogenic variant, and which is 8.1%. And this is our flow. It is done in the molecular pathology department. I don't do it personally. My colleague, Dr. Sushant Vinathan, does this. Okay, and this is the mutation that you can see over here in exon 9 to 14. It's missense variant at exon 9, P286R, which is one of the pathogenic mutations. Now, any questions before we go to 4 short cases, or should I end here?
Before we move to short cases, some of our students have another class.
Sure.
Please, please. Meanwhile, if you have any questions.
Any questions? I can answer those. Yes, madam.
I want you to ask one thing. In the A1, your final diagnosis was endometrioid carcinoma, atypical hypertension. When carcinoma is here, what is the need to change atypical hypertension?
Yeah, true, madam. True. Absolutely. This is just.
Why atypical hypertension?
Absolutely right. This was just for teaching that there were. This is just for them. That the background is hyperplasia, it arises in an estrogenic, hyper-estrogenic background. It was just for them to explain the precursor lesions.
Yeah, but not to write.
No, not at all, not at all.
So I thought you were changing.
No, not at all, ma'am. But sometimes when we have difficulty in diagnosis, say it's a reproductive age woman, we're not sure, then we write atypical hyperplasia, bordering on 2 or endometrioid, or cannot rule out. But you're absolutely right. This, I was just showing them the spectrum and showing them the precursor lesions. But for a diagnosis, we write in the final resection, we write about the adjacent endometrium, and we say it shows. Yeah, absolutely. No, carcinoma away, absolutely, I agree.
Number 2, I want to ask if morphological criteria on multiple data making anti-infection, but shows that it's carcinoma may be. It don't need for going for IST.
Absolutely correct.
Because it is not related to the prognosis of the case, it is just for diagnosis purposes.
Yeah.
So when your diagnosis on NT is confirmed,
Yeah.
then there is no need because just wasted the money of the patient.
I totally agree with you. Absolutely, ma'am. I do agree with you.
So they don't need of IST or any other test because in our time, I'm the employee of that time and there are no IST. Just to do ethics or cytochemical training. And in this cytochemical training, they were born nutrition training, external training, basic training, terminal training, all the diagnostic, all the tumors were diagnosed by on this.
Absolutely.
So, but now, and I think we never heard this, any report bound or any report contradicting or standing in the court, nothing.
Absolutely.
Yeah, just based on ethics and cytochemical.
I totally agree. That's what I said, ma'am, that the basic, the foundation, even now in WHO is good H&E, may be aided by immunohistochemistry when you're in trouble, to maybe pick up some newer variants or newer subtypes. But molecularly, even if you find sometimes an ambiguous angry, which you may call high grade, turns out to be a pole E, then you may need to tailor the therapy. So all this has come, the molecular has put objectivity to the subjectivity.
You know, after my retirement, I joined a hospital, data hospital, and here I started a DNP board meeting also. I get new pathology. I'm surprised if I say that BT and what is this BT? But they have not heard names of these cytocommercial training. Those are doing MDs from medical colleges. They know only ILC, they do not know cytocommercial training. They know, some of them know PhD training, that's all, but no idea. And if I ask what they use of PhD, are you presented, are you presented ethically, they do not know. So this is my request to the teacher. This is my request to the teacher that please tell them the basic first, then from modern medicine and then because ethics after that cytochemical training and then IST or molecular. So just give them basic so that they can survive. Because when you sit in a side effect, you will not be able to give a proper diagnosis and you will not have the confidence. You are right without IST. So you are losing confidence without IST that you are correct or not. So our aim should be, as this is my suggestion to the teachers, that they don't feel they are confident enough to give a proper diagnosis on HCC. And if then they can go for empirical. In Vivekanand, they were not doing this, we did actually first. I developed it, I taught the resetting the tactician, now they are doing it. So just please concentrate on the basic and then advance.
Last one question.
Sure.
It was a wonderful talk.
Thank you.
TV is working since 2015. So,
Thank you so much.
but one thing I want to, I do believe many, but one thing I want to know is in the hyper mutation category, it appears that there are more mutations.
Yeah.
So it is surprising why, we have in the hematopathology, we have, like perception that, when the mutations are more, the prognosis becomes more poor.
Yeah.
We have more and more markers. Here we have less markers, no IC markers, and prognosis also good.
Yeah.
So, isn't it contradictory?
Absolutely. So, in this, as I explained why MC poly has excellent prognosis. Why? Ultra mutated, many mutations, many new antigens, more enhanced anti-T cell response. So, anti-PD1, anti-PDL1, and therefore they respond better. MMRD, less mutations, but many, hyper, not ultra, but hyper.
We have more mutations.
So they have,
more antigens, more
yeah.
IC should be a little more.
No. So they are.
IC markers should be there.
So that's the tumor microenvironment you're talking about. So they attract a lot of anti-T cell response and therefore they do better, but not as well as poly. Poly का जो response है और भी heightened होता है. They have less copy number alterations. Maybe that's what you're talking about. They have a high mutations but less copy number alterations. P53 on the other hand has less mutations but it has more copy number alterations and therefore it is worse. So, yeah, please, no, absolutely, go ahead.
These mutations, that is P53 and MMR and 4, there is another, this that we have some, like, if you look at if there is one more that is copy number variation. That also DNA unstable, and more smaller fragments of DNA will come to the cytoplasm of the cell during the proliferation, and then these small fragments of DNA will activate certain pathways which are involved in the immune mechanism. Now that immune mechanism can be both ways. It can be pro-human, it can be anti-human. But
What I'm suggesting is you can do the short cases with the exam very much. They are not important. So you can take a 5 minutes break. You can maybe that was also. Sure, she brought back everything. हाँ 5 मिनट के लिए नो प्रॉब्लम नहीं वो तो ठीक है हाँ बहुत बढ़िया वो तो मुझे हिमाचल में भी बोलते हैं कि तो अच्छे से समझ में आ रहा है अभी तक अच्छा पढ़ा रही है यू वेरी गुड
Thank you for this explanation.
JR2 can lead at the careers who are being examined by the madam will continue with the short cases. And Madam P.K. Agarwal has been with us with all of her blessings. Ma'am retired as sir just told me in 1997. Means I was born into the medical fraternity at that time. So it's such an honor to have you, ma'am, and you're so active on the WhatsApp group. She's always discussing the cases. It was really nice to have you here, ma'am.
I wish you were there for the ovarian lecture.
Your head can moderate, very executive, and our everything, your energy, you speak for 2 hours and I would tell you the thing that there was time when I was overlate, I was my class. So very nice, very informative, and I'm very good to Delhi. Then what we today in the morning, and I become okay, and we are seeing for next. And actually, I'm surprised. The opinion of God, Oriental cancer, and we are talking of the endometrial cancer. But totally cancer is very important. And this is what the first time I heard that this is the and we are seeing it is related so much academic activity in the department and I would like to thank Dr. Divya, who very modestly and lovingly accepted our invitation to be here for a day that should be commemorated. And when I say commemorated, I refer to the global celebration of the sharing of knowledge that should accompany. Every day we learn, unlearn, and then relearn. I told her yesterday also. I am will be one up meeting. Our HOD sir, who has been with us throughout, and he keeps guiding us, motivating us, all the faculty members, juniors, seniors, residents who are actually the beneficiaries, including us as well. The senior residents, special mention Manish, Rafa, Shalini, Paluma, Meha, Akansha, Tamil. And junior residents who have also made posters for the evening rally, Radhika, Diksha, Tanya, Santosh and all. And it would be just incomplete if I don't name Dr. Shivanji, who has been impeccable in pertinent in making this happen. Actually not persuaded me, it would not just go by with valuable request from Dr. Shalini. So we'll just stop here, whoever has to leave, and then I have but personal invites Dr. Shifa, Dr. Ruchipa is here, Shweta was here, Snouting is here, who are ex-students, the DMLT students, and I really appreciate all of your presence here. So we'll just continue with the short cases. Ma'am wants to leave, and whoever has time with the praise, take time. So shall we begin, ma'am, or shall we continue?
Continue. So I actually finished this lecture in 40 minutes at another occasion because I have a habit, I want to tell everything. That's so that, even if you have this, whatever I know of, I may not know of many things, but whatever I know, I want to tell. And then even in the exam, I had a habit of writing a lot and the teachers would get angry with me. So here it's speaking a lot. So now moving on to 4 short cases. They're really short. This is just to complete the spectrum, which will help the exam going students. Short case A, 57-year-old PH-BSO done at an outside center for postmenopausal bleeding. I'm just showing you a section from the endomyometrium. What do you think? Let's just do this in a Q&A format. I'll finish this in half an hour, this one. Quickly. Yeah, the lady from the fourth. Yeah. You want a mic? Mic? Yeah. Very good. Very good. Very good. You can't do it. I agree with you. Let's look at the solid area. Your next colleague. Next one. How do these cells look? Just describe the cells. Yeah. Yeah, I'll do that because otherwise we waste time. Yeah. Take a mic, please.
Few cells look so monotonous.
Excellent.
They are mildly atypical.
Okay, I like your first answer. I'll take answer A, where you said they are monotonous and they look, what is the shape of the cells? So I have another, just a little bit of a suggestion. When you're seeing cases, be true to what you see. Monotonous hai to monotonous hai. Bolo hai, isn't it? Very good. So what I used to do, I don't know, I'm very honest about my feeling. I used to try to fit things into a book. Don't do that. Ask yourself, monotonous, very good. Are they sticking to each other?
No,
They are monotonous and discohesive. Can you pass it on to the middle? Are they looking endometrioid? They are not looking. So this is you're dealing with a non-endometrioid tumor, at least on this side. Now I'm just showing you the solid area. Can you interpret it? But this is in which area? What do you see in the background? Which area? Was it the gland area or the solid monotonous discohesive area? Okay. Next person. Loss of E-cadherin. What is E-cadherin? What sort of a marker is it? Okay, membranous stain. And what does it signify? Loss of E-cadherin. Discohesive nature. Do you know any other tumors which are E-cadherin negative? Very good. Anything else? Lymphoma? Let's say lymphoma. If you just put an E-cadherin on a lymphoma, ma'am said don't do it unless it's absolutely necessary. I agree. I agree with her. Suppose you put it on a lymphoma. Discohesive, it'll be lost. You put it in a signet ring cell cancer of the stomach. They're all, so it's a marker of adhesion. It's an adhesion molecule marker, isn't it? So wherever the adhesion is lost, the marker is lost. So E-cadherin is lost in this area. Okay. Now next person, please. What about the MMR stains? Very good. How do you know that the MLH1 is deficient and not? Suppose I say it's not worked. But why do you think it's deficient? Excellent. You have to look at the internal control. Suppose you had a slide in which the internal control was also negative. Please don't call it MMR deficient. There is something called constitutive loss also. We won't get into that right now. It was discussed in the previous meeting which we had on IHC interpretation. For now, the internal control has worked in MLH1 PMS2 and it's lost. And the rest two are retained. So, your diagnosis. Why is it dedifferentiated? Go back to the boys now, please. The first boy next to the lady in blue. Yeah. Why was this called a dedifferentiated endometrial carcinoma? So here she said on low power, it's a short case. These are the endometrioid type of glands. Adjacent to it, right adjacent to it is a monotonous discohesive tumor which has lost Pax8 ER. It has lost E-cadherin also. And this tumor is MMR deficient. If I did Pax8 on this area, the gland area would be Pax8 positive, ER positive, E-cadherin positive, but the adjoining area is ER loss, Pax8 loss, some amount of cytokeratin and MMR loss. Why is this not a carcinosarcoma? Now I'll call this area sarcoma. Do you agree? You need markers for carcinosarcoma. Which sarcoma will look round cell like this? Embryonal RMS, have you seen? They can look, so you have to be careful, but carcinosarcomas are MMR deficient, they are MMR proficient generally, many times, and your dedifferentiated are MMR deficient, okay? And this was Desmond negative and MyoD1 myogenesis. There were no rhabdomyoblasts in this area, okay? So this is a low-grade endometrial cancer on one side and a monotonous solid area just adjacent to it. The nuclei of the solid area is different from the nuclei of the endometrial glands, okay? They are not the same. They are not oval. Therefore, this is not grade 3 endometrioid. You can say that this is grade 3 endometrioid. Can this be grade 3 endometrioid? Grade 3 endometrioid, the nucleus of the solid area will be similar to the nucleus of the low-grade areas. Paxate will be retained in the grade 3. E-cadherin will be positive in the grade 3. ER will be positive in the grade 3. So be careful in the differential diagnosis of dedifferentiated endometrial carcinoma. So this is the next type of high-grade endometrial cancer, which is your undiff or d-diff carcinoma. What's the difference between undiff and d-diff cancer? What's the difference?
अनडिफरेंशिएटेड कार्सिनोमा में होता है वो थोड़ी सा हमें बैकग्राउंड में आगे को डिफरेंशिएट कर लेने ये morphology थोड़ी क्लियर होगी बट डिफरेंशिएट में बिल्कुल भी डिफरेंशिएट नहीं कर पाते.
Very good. So dedifferentiated में you get a low grade area जो endometrioid जैसा दिखता है and a sudden change of a monotonous almost lymphoma looking like area, you know. It starts looking like a neuroendocrine or a lymphoma or something totally different. But in undiff, there is no low-grade area at all. It's totally monotonous. There is no low-grade, and that can be a little difficult to pick up. All right. So undiff carcinoma is a solid pattern tumor lacking overt morphological evidence of epithelial dispensation except by IHC, perifocal CK and EMA. D-diff is an undiff cancer found in combination with an endometrioid carcinoma with a low grade. So low grade plus monotonous solid area is equal to D-diff. Only solid area, no low grade glands or anything is equal to undiff. Okay. These represent 10% of high grade cancer. They are very aggressive. All right. So you can make out this discohesive, as she described it very well. I didn't get your name, who described the monomorphism. The first thing she said is monomorphism. So please believe your gut and say, this nuclei are monomorphic. They're not looking like endometrioid ka nuclei. Look at it, it's so alag-alag, dur-dur hai, discohesive hai. So this cohesive pattern can sometimes mimic, suppose you only see the discohesive pattern, you have DDs, lymphoma, plasmacytoma, high-grade ESS, small cell carcinoma. So you be a little careful. Okay. Now, approximately 40% of undiff cancers are associated with a FIGO grade 1 and 2. The differentiated low-grade endometrioid component is sometimes found in the lining of the endometrial cavity, but deep to it you have the D-diff. So sometimes in a biopsy, you may call it, that's come out. So you'll call it low-grade. पता चला रिसेक्शन में सिर्फ उसकी TSBSO हुआ, sentinel lymph node हुआ, पता चला deep में D-diff निकला. Then second surgery. Till pelvic, paraortic, comentectomy. So, can you help it? Yes, you can. If with a FIGO 1 and 2, you are seeing areas of extensive necrosis, write a comment in your report. And on my biopsy, I'm seeing FIGO/1 and 2. It's looking low grade, but I see necrosis and extensive, not little bit. I see extensive necrosis. This may imply deep myoinvasion. So you check your MRI. Or a component of a unsampled sarcoma. And then you check your MRI. If the MRI is showing less than half, you can say this could still be, keep a note of the necrosis so that you have given a warning and an upfront extensive staging can be done. But not always. Don't overcall the necrosis also. Okay. Sometimes, rarely, you can see the low grade in the uterus, your undiff and D-diff cancer. Now, majority of the undiff areas lack Paxate ER/PR, but 20% can show focal staining. P53 is usually wild, and more than 80% will show some CK and EMA. In this area, you have to do a neuroendocrine marker. Not have to. If you have it, you can do it. As madam said, everything may zaruri nahi hai because it will remain a high-grade cancer. Because up to 10% of the cells, if they show some synapto, it's okay. But if more is shown, then it can be a neuroendocrine carcinoma component, which is again a high-grade endometrial cancer. Treatment is not going to change. This is just for your theoretical knowledge that the undiff component is actually is not undiff really, it's a neuroendocrine carcinoma, which can happen. Now, these tumors show mutations in SW1, SNF1 complex, and these are expressed by loss of expression of BRG1, INI1, ARID1, and ARID-B. They follow this pathway. You people must be doing so much of theory, and you therefore know this pathway. Okay? And the most important differential diagnosis we discussed is grade 3 endometrioid carcinoma, serous carcinoma with a solid architecture, lymphoma, plasmacytoma, melanoma, ESS, high-grade neuroendocrine. That also is a differential. In that, the synaptochroma will be very strong. In undiff or D-diff, it will be less than 10% of the cells show synaptochroma. Metastatic, RMS, etc. All of them come in the differential diagnosis. Very important to distinguish redifferentiated endometrial cancer from FIGO 2 and 3. You can do it on morphology itself. You won't find it monomorphic. You won't find it discohesive. You'll find a solid sheet with the nuclei are similar to the endometrioid. Therefore, you will know this is grade 3 and not a dedifferentiated or an undifferentiated carcinoma. Short case B, next boy, 65-year-old female, again THBSO done at an outside center. I'm just showing you a section from the endomyometry. Can you describe the low power? Avoid using focal. Everything focal, mild, moderate. Be very strict with these words. Control yourself before you want to say focal. Take a mic. Don't worry, no one's going to scold you.
Endometrial gland with the diabetes and blood vessel.
Okay. Okay, next person. What can you see? Sit down.
Clinical pattern is missing.
Anji?
Atypical cells are seen.
Which cells? Atypical cells. Okay, another thing, control yourselves when you say atypical. Control. So like this, I won't say atypical. Malignant, not malignant. Chalo. Malignant लग रहा है? ये normal endometrium लग रहा है? Normal endometrium गोल वाले glands लग रहे हैं? Malignant है? Yes or no? Benign है? नहीं पता. Next person. Benign or malignant?
I think how it looks
Malignant. You can see some crazy stuff happening, right? What do you see on the top? What do you see in the bottom? I'm giving you a hint.
at the periphery of the lesion.
Yeah.
Shows
Let's say this is top and bottom.
yes, on top of the lesion, it looks like some broken glands or papillary.
Very good. Very good. And then pass it on to the first person. You can start. What do you see in the bottom? What do you see in the bottom? What do you see here? So she described the top. She says she sees papillae. And do you see the papillae in the... You feel they are invading, okay? This is the bottom. What kind of cells are these? There's some bone formation. How are these cells? Describe the cells. Are they blue? Are they pink? Are they sticking to each other? Are they discohesive?
The cells are discohesive,
Very good.
highly pleomorphic,
Very good.
very nuclear clearing.
Clearing. I thought they were pink. Okay, 1 second. It's not the best.
It is more of appearing pink.
Pink. Okay. And in the center?
Calcification.
Okay.
Center.
Okay. Okay. Now, this is the top part of the gland. The top part, what she described as a papillae. Describe them. Does it look endometrioid? I'm going back to the top. She wants to do it. She said, nahi de rahi. Haan, batao. She's not passing the parcel. Bataiye.
The cells are pleomorphic.
Endometrioid? No. Okay. Next. Go ahead.
These are pleomorphic, prominent nuclei, arranged papillae
Okay.
pattern, and are not that cohesive.
Okay. But they're cohesive here. They're forming a lining of a gland. What about mitosis? Actually, they are there here. This is a mitosis. This is a mitosis here, here. This view isn't the best, but it's okay. Now, this is the bottom. Next person, let's give the other person a chance. This was the bottom part of the tube.
There are many cells which appear plasmacytoid having centrally placed nuclei.
Centrally or eccentrically? Eccentrically, okay.
Abundant cytoplasm. All the cells are discohesive and it is ultimately a mitotic figure.
Okay.
Center of the
Okay. From what's the cytoplasm like? Eosinophilic. Next person. You want to give the name to this cell? Very good. It's a rhabdoid looking cell. So on top you saw glands, papillae lined by highly pleomorphic cells. They were cohesive on the top. Bottom you found these rhabdoid looking cells, discohesive, not forming glands. Up and down there are two things. Next person. What do you think it is? You want to do IHC or you have, madam won't do IHC. I also won't do IHC. Unless, because I've come to teach here, I will show you that and show off that I have IHC, and so do you. So, but she's not going to like it if you didn't. Excellent. There is an epithelial component, there is a sarcoma component, which looks like an RMS, and a rhabdoid, and this is, there's a heterologous differentiation of two types, maybe a rhabdomyosarcoma and maybe a osteosarcoma also, who knows. So, this is a carcinoma plus sarcoma. Carcinosarcoma, earlier it was called triple MT, now it's called a carcinosarcoma, is enough. And you really don't need IHC for this. But going beyond what, if this turns out to be pole E, and there is no rule to say right now that don't give it adjuvant therapy, you will give it. But it will be, so it's not, suppose I have a carcinosarcoma and I'm getting adjuvant therapy. Won't I want to know when will I die, or like how am I going to behave? I want to do a poly on me and say, oh, maybe I'll see my son get married, or these are important. So everything is not treatment. There's something you want to tell the patient how long you will live. You want to, or ya sari movies dekh lo ek hi mahine mein, bete ki shadi kar do. So these are very important questions. So even carcinosarcomas need to be subjected to poly as per the current guidelines. But we will do it if, depending on the stage or in an MDT discussion, if the patient wants to know the prognosis. But anyways, these are at high stage and they do quite badly and they need chemotherapy. But if they are poly, many of them actually have a better prognosis. So let us put IHC just to prove a point. The top one is CK positive, the bottom one is CK negative. The top one is Vimentin negative and the bottom one is Vimentin positive. Okay? And you want to prove what those rhabdoid cells are. They are positive for desmin and myogenin. So this is a carcinosarcoma with heterologous rhabdomyosarcomatus and maybe some bone formation as well. So this is the next type of high-grade endometrial cancer, which is your carcinosarcoma. It's a biphasic endometrial carcinoma with a component of high-grade sarcoma juxtaposed with a high-grade carcinoma. Now the other day somebody was asking me a question and showing me the case and said, what is this carcinoma? Is this serious? It's looking funny. It's looking. It's a carcinoma. So don't try to subclassify that carcinoma. It can be high-grade endometrioid. Most often it's a serous. But it can be anything. It can be clear cell. But if you have sarcoma plus carcinoma, it's equal to a carcinosarcoma. Okay, you can do a molecular testing on it, but don't try to split hairs and say what type of carcinoma and what type of sarcoma. If it's very evident to you that this is RMS, you can easily write it. You don't have to break your head on that. Now, a high-grade carcinoma component admixed with a malignant mesenchymal element is a carcinosarcoma. It's usually a sharp demarcation, but sometimes there is an admixture. In this particular case, it was sharp. Top is sarcoma, top is carcinoma, bottom is sarcoma. Now, imagine if an endometrial curating came or only from the top part, you will call it maybe serous, but serous is anyways high-grade. They'll do a full surgery. So you're okay with it. And then it turns out to be a carcinosarcoma. Another interesting thing, the Mets are usually a carcinoma of these, but the overall case you label it as a carcinosarcoma. Met can only, the lymph node met or can only be the carcinoma component. Your omentum may find only the carcinoma component. But if your uterus has both of them, it should be called a carcinosarcoma. Now, do you want to do IHC? It has a limited role. This is morphology. Okay, you don't really do it, but if you want, suppose there is a round cell component. You're not sure it's undiff or embryonal RMS. I have a case, I couldn't bring it because I just signed it out and my scanner was busy with the IHC conference that we had. It was looking like an undiff, monotonous. I didn't have much time to spend on morphology that day because we were busy. I said, I just want to rule out embryonal, and lo and behold, E-cadherin was also negative because it's an addition molecule. But it was desmin myogenin strong positive. It was an undifferentiated, the embryonal type of RMS, which was looking like round cell, like a small round cell tumor. Okay. Now, how much of sarcoma do you need to call it carcinosarcoma? Literature may varies from 2 to 25, but is there any objective? Thoda sa dikh gaya. Kitna? How much is that? The ISGIM has said at least 1 millimeter of sarcoma has to be there to call it carcinoma, the carcinosarcoma. This is not an evidence-based thing. Now, how do you want to classify the carcinoma as carcinosarcoma? Homologous, heterologous. These are just academic exercises. For therapy, it doesn't matter because carcinosarcomas are not treated like sarcomas. They are treated like a carcinoma. If you call it RMS component, they're not going to give it ifosfamide or the sarcoma protocol. They are going to give you the platinum the taxane protocol. So a carcinosarcoma is not to be treated like a sarcoma. You need not say that how much, we do it as an academic exercise, that 60% sarcoma, 40% carcinoma, sarcoma is of the RMS, the carcinoma is serous. We may do them as academic exercises. So your mesenchymal component, remember, but it's good to know that your mesenchymal component can be even an ESS or an LMS. That's of the homologous type. So intrinsic to the uterus, endometrial stroma is intrinsic to the uterus, the sarcoma can be an ESS. LMS is intrinsic to the uterus, the sarcoma can be an LMS. So don't think that can't happen. That's a homologous type of a carcinosarcoma. You can have a heterologous type of carcinosarcoma where it's extrinsic to the uterus, like a chondrosarcoma or an osteosarcoma or a rhabdomyosarcoma in this particular case. Does it have significance? No, they're all treated like a carcinoma, but it's a good academic exercise, particularly in your post. You should know how to differentiate these tumors, and it's a good academic exercise. Accurate subclassification of the sarcomatous component is a useful exercise, but not relevant to the management. But I do it because it keeps your morphology strong. You have trainees with you, they should be able to do it. So I do it as an academic exercise. Important thing, how will you distinguish carcinosarcoma from dedifferentiated? Carcinosarcoma behaves a little worse than dedifferentiated. The carcinoma component is usually serous. In dedifferentiated, the carcinoma component is usually endometrioid, but this is not the rule. Type of cells in carcinosarcoma, the sarcoma has the spindle cells or the rhabdoid cells, but I told you an embryonal RMS can look like the monotonous undifferentiated carcinoma. But the DD you see, or the dedifferentiated, is always discohesive monotonous. Heterologous element अगर दिख गया, जैसे इसमें था, there is this bone and then this rhabdoid, you know this is a carcinosarcoma. Sometimes you can have a sarcoma with a undiff carcinoma. Your epithelium is an undiff carcinoma, your sarcoma is a sarcoma, that is also equal to a carcinosarcoma. Do you understand that? So heterologous elements are common in carcinosarcoma, they are not common in dedifferentiated. And MMR, I use it a lot to distinguish carcinosarcomas from dedifferentiated uterine endometrial carcinomas. So MMR is lost in dedifferentiated, as I just showed you the previous case, and not in majority, but very rarely in carcinosarcomas. Very, very rare. But I have had a case of MMR deficient carcinosarcoma as well. Lastly, the mixed endometrial cancers. I don't have a case, but this is a term you need to use very strictly. It has to be morphologically mixed and confirmed by immunohistochemistry. So here I would disagree with Madam a little bit. If I want to call something mixed, I am not going to just do it on morphology. The reason is, if I have an endometrioid, low grade, say grade 1, grade 2, and I'm finding a clear cell area, any amount of clear cell is going to convert this case into a high-grade endometrial cancer, irrespective of the percentage. Earlier we had 30, 15, all those percentage. Now no. Any amount of a clear cell or a serous is going to convert this case into a high grade. Remember, grade 1, grade 2 endometrioid are low grade. Treatment is different. The minute I see a high grade component, so now if I want to really say this is mixed, you have to do it by morphology plus IHC. This is one place, because you're changing the management and you're changing the prognosis of this patient, you have to use IHC, and this is the guidelines. So, and mixed carcinoma has two histological types. It could be a serous or a clear cell with an endometrioid. Don't count dedifferentiated and carcinosarcoma as mixed. They are not mixed. So it's desirable to have IHC demonstration of the two distinct types, because you're converting a low grade into a high grade by any amount of serous or clear cell present. So each tumor type should be a distinct component on H&E. You should use IHC. So for serous, if you see aberrant P53 and diffuse block like P16, and for clear cell, this is where I use a napsin. I just don't throw a napsin on every case. Here I will immunohistochemically prove that this is clear cell and only then call it mixed. No minimum amount of serous or clear cell component is needed, as long as it is recognized confidently on IHC, on H&E and confirmed with IHC. You should report the percentage of each, but the percentage doesn't matter. Even 1% serous will make it a high-grade cancer. Overall, it is a grade 3, irrespective of the percentage of serous and clear cell. Okay? These are the ISGIP recommendations. This is not a case, it's a picture where you see a low-grade endometrioid on this side and you see a high-grade serous on this side, and you have proved them with immunohistochemistry. This side is P53 mutated and this is wild. We've also proved it with P16. The endometrioid is P16, lack of block, and the serous is block. So here you have to interpret it carefully. Just if you see some patchy P16, doesn't mean that morphologically it has to be different and your P16 has to be different. So it is a combination of correlating H&E with IHC. Short case C, 60-year-old lady, postmenopausal bleeding, endometrial biopsy at another hospital. It was called just high-grade endometrial cancer. Happens, and that I think is fair. Slides and blocks were submitted at TMC for review. The cervix and the vagina were normal. Radiologically was not available. No radiology was available initially. So we only got the endometrial biopsy. How does this tumor look? Who was the next person? Just the last case. Is it okay? One more case? Okay. Yeah. The targeted audience. Great. Yes, next person. Bravely take the mic. Mic, please. Sorry, microcystic and glandular pattern. Okay, very good. Then? Very good. You're seeing mucin and this power itself. Very good. Very good. Okay, let's go higher. Don't sit down. Now? No, don't sit down, please. High power.
cells are pleomorphic.
Sorry?
Cells are pleomorphic.
What is it?
Pleomorphic.
Pleomorphic. अच्छा, cells are pleomorphic. हाँ, good. They are.
Having high incidence.
NC ratio दिख रहा है आपको इस? हाँ ठीक है, blue लग रहा है. Okay. NC ratio high होगा. हाँ.
Post chromatin.
Cause chromatin. Chromatin दिख रहा है आपको? इस पावर में जो दिख रहा है बताइए. So another thing, we won't cook up stories. I promise. I tell myself also that we will just say what we see, and we will clench. I clench my thing very badly when I'm very tempted to say something which I shouldn't say. So that holds good for interpersonal relationships also. Yeah. ठीक है, glands दिख रहे हैं आपको. Describe the arrangement of the glands. Very good, stratified है. Okay. Necrosis दिख रहा है आपको कहीं पे? Glands के बीच में देख focal necrosis दिख रहा है. Okay, next person please. अब आपको क्या दिख रहा है? जो उनको दिख रहा है elaborate कीजिए.
Stratification है.
Very good. Pseudo stratification है, columnar है. हाँ जी.
Intestinal type की gland लग रही है.
क्या है?
Intestinal.
Very good. Intestinal gland. 100 out of 100. आपको थोड़ा सा colon का feeling आ रहा है इसमें. Garland type of necrosis दिख रहा है. Very good. Endometrial में Garland type of necrosis दिख रहा है. ठीक है. Great. Next patient I would say. Next person. इसमें और क्या दिख रहा है जो पहले में नहीं दिख रहा है? Lymphocytic infiltrate. Very good. ये वाला देखिए जहाँ मेरा arrow है. Goblet cells. Okay. Goblet cells दिख रहे हैं. Excellent. So जो दिखे objectively you should see it and say it. Goblet cells दिख रहे हैं. So what does that make you feel? इनको goblet cells दिख रहे हैं, इनको cribriform cells, glands दिख रहे हैं, Garland type of necrosis दिख रहा है. Intestine लग रहा है आपको? Okay. Endometrium में intestine आ सकता है? Mets हो सकता है. Very good. Very good. Next. This is the cervix. Describe the cervix, though I have written in the heading. No, I have not written what it is. Describe it.
This tissue section shows cervical glands, tortuous cervical glands, and loose cervical stroma.
Is it malignant? Okay, next. आप बताइए. Malignant लग रहा है cervix? ये जो bland लग रहा है मेरे को. आप बताइए next. Bland लग रहा है ना? Endocervical glands हैं. Not so bad, right? Not like that Garland necrosis. ठीक है. Cervix normal लग रहा है. First panel डाला हमने on those cribriform glands. Interpret कीजिए.
एक साइड में PR पॉजिटिव पर ग्लैंड में नहीं आया है. इस स्टेज नेगेटिव है. मतलब ब्लॉक पॉजिटिव
नहीं है. और PR पॉजिटिव है कि नेगेटिव है? कि फोकल है कहीं पर जो आपको दिख रहा है?
ग्लैंड में नेगेटिव.
तो किस में आया है?
Internal control है.
Very good. Stroma में आया है. Next person please. So PR is negative, he says. The stroma, it's worked well because the stroma is positive. He says P16 is not blocked, like 100 out of 100 on that. Second panel.
Focal positive.
I told you what you're going to do when you want to say something focal. You control yourself, make sure, and then say it. Vimentin, back to Vimentin. What do you think? कहाँ positive आया? इस focal बोलने के पहले आप सोचिए. हाँ, तो ये gland में नहीं आया है, more or less, isn't it? More or less your glands are negative. जो आया है lymphocytes में आया है, and it's come in your stroma. The glands are negative. Then P53 बताइए. तो हम P53 को positive negative बोलते हैं एग्जाम में कि कुछ और बोलते हैं? एग्जाम में क्या बोलते हैं? Wild or very good. हम positive negative नहीं बोलेंगे इसको. Wild or mutated. So what is it? Wild or mutated? Okay. Next, you want to say something about the P53? What's the intensity of the staining? Actually, the picture is not. It's very looking. The contrast is such. It's not so strong. Many areas are negative over here. Actually, it's seen very well in this contrast. It's wild type. It's not strong, diffuse, dark brown. This is also like the Rajma. which cannot be different in different houses. It has to be strong diffuse staining. The cutoff is 80. In my house ka P53, it means my laboratory ka more than 95%. It's how you validate the stain also. So more than 95% comes strong diffuse positive, nuclear positive. This is heterogeneous, kahin pe hai, kahin pe nahi hai. This is a wild P53. So Vimentin negative P53 wild. Napsin negative. जरूरत था डालने का इसमें napsin. कहीं पे आपको clear cell लग रहे थे?
Yes.
So madam said, you don't waste ILCs. You think it's a wise thing that I did, that I put napsin? I told you don't put it. So not a wise thing. Thrown in, just, it could have come. Thrown in just because ER is coming negative, PR is coming negative, someone gets frustrated. One of those days, and you're signing something, someone says, ma'am, napsin डाल दे, हाँ डाल दो. But अगर कहीं positive आ गया, आप इसको clear cell बोलोगे? So wrong thing on my part to not to pay attention and say हाँ napsin डाल दो. अगर वो secretory वाले कहीं mucinous वाले areas में आ सकता है napsin. So I'm not going to call it clear cell. So कोई use नहीं है. Madam is right. कोई use नहीं है इसमें napsin डालने का. Anyway, napsin was negative. This is just third panel. Next person. Interpret it.
CK7 is positive in the gland, CDH2 is positive, and CK20 is positive. So
Now do you want to use the word focal? Focal है ये. So you want to say focal? I said control yourself and tell. Yeah, नहीं ये focal है. Release your chest. This is focal. This is real focals. Because see here it is focal. So 7 positive, CDX2 strong positive. CDX2 is what kind of a stain?
membranous positive.
CDX2 is membranous. CK7 is membranous. CDX2.
Sites positive.
Next person. तो membrane हो गया, cytoplasm हो गया, दोनों नहीं है. क्या बचा? It's a nuclear stain. Okay, so CK7 positive, CDX2 strong nuclear positivity, and CK20 focal positive. Paxate interpret कीजिए.
Positive.
थोड़ा positivity आया इसमें, which not as strong and diffuse जैसे आना चाहिए, but it came. And we have two monoclonal MRQ50 and we came like this, okay, with the monoclonal Paxate. So this was the summary. CK7 strong, CDX2 strong, CK20 focal, Paxate truly focal. It was not very diffuse. ER negative, PR negative, P16 lack of block, P53 ideal thing should be wild and not non-mutated. Wild is a better way. GATA negative, napsin negative, Vimentin negative. So a diagnosis of adenocarcinoma with gastric enteric differentiation was given, and endometrial origin was favored because the patient का कोई imaging नहीं था, but Paxate हल्का आया था and aspiration में आया है. Unlike she had no GI symptoms, but we ruled out a GI primary before considering an endometrial primary. And they did an upper GI, lower GI colonoscopy, and it was all normal. Then I spoke to the clinician and said, this is before the era of the new WHO that you do. It's looking like a GI kind of a look. There are some papers, there were just a few papers about GI differentiation, and those are aggressive tumors. So I said, you go ahead. I can't write high grade, low grade and all, I don't know, but they are the ones with intestinal can sometimes show aggressive behavior, do everything. So they did pelvic, para-aortic and omentectomy. And this is the dissection, which looked similar to the, nothing different, similar to the biopsy, okay? And then by that time, the WHO had just come in and the online version was available. And I looked at other endometrial carcinomas. There's something called a mucinous carcinoma or a gastric or a GI type. And this was an endometrial gastric GI type adenocarcinoma. PT1A N0, no LVSI. Why was this called gastric type? It had a gastric type morphology with some goblet cells with no evidence of any other primary site. There was no typical endometrioid component. The cervix was normal and the cervix was completely put in to make sure this was not coming from the cervix. It had at least one IHC marker of a GI differentiation. Ours actually had two, CK20 and CDX2. I don't have a MUC6. There was no expression of ER in my case, as you saw. So this is the paper by McCluggage, the endometrial gastric GI type mucinous lesions. a report of a series illustrating the spectrum of benign and malignant. You must read this, is an excellent paper, where they describe type. All 4 cases showed gastric morphology, 1 showed goblet cells, 1 showed mild atypia, and others show moderate atypia with mitosis. 1 showed necrosis, like our case. Myometrium invasion was superficial in 2 and deep in 2. Mine was PP1A. Lymph nodes were negative in all. Now, how does it matter? Isko main GI bolu. Yeah, this is the new entity in the WHO. Yeah. So why is it important? And this is the new entity. This is where it is. One second. This is where it is under in the new WHO under others. Okay. And now, why is it important? Let's call it endometrioid with mucinous. Why is this not endometrioid with mucinous? There is no ERPR. Endometrioid with mucinous will be ERPR. There will be some endometrioid morphology. Okay, there is no ERPR in this. That's why it's not endometrioid with mucinous. Why is this not a GI? Radiologically, there was no GI primary. The CT was fine. Upper GI, lower GI were fine. So it's not GI. Why is this not cervix? P16 was lack of block. So why is this not the gastric or the pyloric type of cervix? That can be P16 negative. The cervix was completely sampled. It was not arising from the cervix, because for that you have to rule out a cervix primary by completely, and this was in the fundus, whereas it's really far away from the cervix, and the cervix has to be sampled completely to rule out a non-HPV mediated gastric type endocervical primary. Okay, now as I said, हर exercise का एक meaning होता है. इसको क्यों बोलना है कि this is GI? Because you first have to rule out a GI primary as cervical primary, which can be aggressive. Endometrioid with mucinous will behave very well. These are very aggressive tumors. If you call it low-grade endometrioid and you don't stage it completely with pelvic para-aortic and omentectomy, these are very aggressive tumors. Okay, and they are very, very rare. Last case, and really sorry for taking so much time. I thought instead of bringing cases, I can discuss them with history. It will have a bigger impact. 49-year-old female. Now this is a very long and complicated story. She was a case of CA endometrium post-TH-BSO at an outside center in 2017 and had already received adjuvant therapy. Then she came to TMCK somewhere around 2019 and she had lung mets. So an endometrial cancer with lung mets, you don't see them that often. And since radiotherapy mila, so in my head I was thinking, must be an intermediate risk which only got radiotherapy. And intermediate risk is coming with lung mets, right? It's amazing, right? It doesn't happen. Anyway, this patient for lung mets underwent a right lower lobectomy and then received chemotherapy because it was metastatic. Now, anyway, this case also I hadn't seen this, I hadn't cited. Then in 2022, I got a specimen of a abdominal wall mass from this patient, okay? So, known case of CA endometrium, treated with radiotherapy, then got lung mets, underwent a lobectomy at my center where it was called Mullerian primary in a known case of endometrium. I'll tell you that story later, but I was interested in my specimen, but you cannot be just selfish and interested, you have to take out the whole case. So I took out the prior as well, but that's not what I'm going to show because it's a short case. I will just show you sections from the abdominal wall mass. Yeah, next person. It was a solid cystic mass on gross. So now. Very good.
And towards the right side it shows the solid component.
Very good. Continue.
And these
what is the arrangement?
glandular.
Yeah. Glandular, papillary. Yeah. Very good. How's the tumor looking? Is it looking pink or blue? The next one. What do you see here? Here, if you can see my arrow. Some clearing, some squamoid looking areas. Some solid areas you can see with these slit-like acini. What is the arrangement here? Retiform, looking like the rete a little bit. A little retiform, branching, glandular, something like that. So different architectural forms in different places, right? Glandular, papillary, solid, squamous, but blue. And what do you see in the lumen? Sorry? Eosinophilic colloid-like secretions. Some solid areas in microacina. So it's a weird-looking tumor. So we did a Paxate. Paxate is strong. This is how Paxate comes, strong diffuse. Okay. Now it was looking endometrioid in some places. Very honestly, it's got columnar nuclei, but it's very blue. ER/PR are negative. What is the next marker that you want to do? Or do you know the diagnosis since you're in final year now and giving exams when? But they won't kill you if you don't know this diagnosis. But if you know, then they'll be very happy and maybe give you a +5 and forgive you for something else. It's a है, ER/PR negative है. Lumen में colloid-like material है.
Glands है, papilla है, solid areas है.
New entity भी है.
Blue है.
But anybody? Next panel. Okay. Now, GATA3 strong diffuse nuclear positivity and TTF1 strong diffuse nuclear positivity. So, what's your diagnosis? Adenocarcinoma of the lung metastatic to the uterus with aberrant PAX8. With aberrant PAX8 paper. Yeah, fourth person there. You're saying something, you're angry with my diagnosis. You should.
I'm sorry, I'm struggling my mistake, but I think it's TTF1 is positive, thyroid, vaccine is positive, thyroid, and again it
Doesn't seem to be thyroid. So it's not thyroid. Lung, he had a lung mass, na? Lung mass tha. And PAX8 आ सकता है, maybe आ सकता है lung में. इतना strong नहीं आता. Monoclonal PAX8 है. And GATA भी है. Anybody. It's a mesonephric-like carcinoma of the female genital tract origin. Why mesonephric? What is mesonephric adenocarcinoma? What is mesonephric-like adenocarcinoma? What is the difference between the two? You know there are mesonephric rests. If it arises from the rests, it's mesonephric carcinoma. If it arises from an area where they're not supposed to be rests, like the endometrium में rest नहीं होने चाहिए, cervix में होते हैं. So cervix में if you have a tumor like this, you call it mesonephric carcinoma. But in the uterus, you're not supposed to have rest. So you call them mesonephric-like adenocarcinoma. The mechanism is they arrive from transdifferentiation of those cells. It is transdifferentiated into a mesonephric. So mesonephric differentiation is making you express PAX8, GATA, and TTF1. Now, I'll go back because we have time to the lung case where in 2019 this was not really described and my colleague actually said that this is endometrioid with some aberrant TTF1 and it's high grade and could not did not thank God call it lung and PAX8 was quite strong. So strong PAX8 monoclonal does not come in lung primary, okay? It comes in thymic tumors but not in a lung primary, right? So this is involved by a mesonephric-like carcinoma of the female genital tract. These tumors share morphology, IHC and molecular similarities, both mesonephric and mesonephric-like. Mesonephric shows definite evidence of mesonephric remnants, which is not identifiable in a mesonephric-like carcinoma. There are no remnants in mesonephric-like. Very typical feature is small tubules with this eosinophilic colloid-like material. Another is it looks very blue, unlike an endometrial carcinoma, which has more cytoplasm. This is less cytoplasm. And a variety of architecture, papillary, ductal, retiform, solid, spindle. I showed you all in this case. In keeping with the mesonephric origin, these tumors show dual positivity of GATA, PAX8, and they also show TTF1. But jahan par GATA is strong, TTF1 will be weak. Where TTF1 is weak, GATA will be strong. That's how it is. I have no experience with CD10. People say it shows a luminal staining. Whenever I've tried to do it, in the initial, now I've stopped. It doesn't matter. You pick it up on morphology, combine GATA, PAX8 and TTF1, it's a good stain. So in a metastatic side, don't call it Be careful, mesonephric will be showing TPF1 and don't call it lung primary. Remember, it's not endometrioid because they're ERPR negative and GATA positive also. So they're ERPR negative, P53 wild, and the mutations are KRAS and ARID1A. So a quick summary of what's new in gynae pathology, particularly in the endometrial epithelial tumors. Your molecular classification is new. You know that there is no surrogate marker for poly, but there are surrogate markers for MMR deficiency, for P53 mutation. There are surrogate markers, and the lack of all three makes it NSMP. Molecular features, we know now that 30% of serous carcinomas of the endometrium show HER2, and you should do it in your upfront. We do it in upfront in our cases of all endometrial serous, not endometrium ovary. We keep that information because endometrial serous are high-grade tumors and they are very aggressive. They can recur. With that information, the oncologist has it right in the beginning. If they recur, and if they are HER2 amplified, they can be given trastuzumab. There are novel type of tumors which I have just shown you, a gastric type or a gastrointestinal type. I showed you a mesonephric like. Also remember that carcinosarcoma don't waste a lot of time. It is to be treated like a endometrial carcinoma, not like a sarcoma, and please don't call it a mixed tumor. The clinical implications are many, and you need very good morphology, as Madam said, because your most important job is to distinguish endometrioid from non-endometrioid. And I think I spent a lot of time in showing you what endometrioid looks like and what it should not look like. So that's your first job. It is very important to do MMR on all cases. I told you why. It's got an intermediate prognosis. You can identify patients with Lynch syndrome, and later these patients can be given immune checkpoint inhibitor therapy when they recur. MMR, I use it personally also, and I think it's very useful to distinguish the endometrioid histology from serous if you're confused, and also endometrial from endocervical. Very useful. Okay, it's helped me many times. HER2 testing is very important in endometrial serous. Do that if possible if the patient pays. That information can be used later when the patient recurs. And a recognition of poly, I showed you a case which was called was supposed to be high intermediate risk. The minute we did poly, it became low risk and the patient did not get toxic chemotherapy and very, very uncomfortable radiotherapy. So with that, I thank you all for a patient hearing. So I thought that cases would be better. Because we don't practice just pathology behind a microscope. As I said, we work hand in hand with our clinical colleagues. And if we take a case as a whole, if we think of the patient just like the clinician does, we will do a better job and they will recognize our importance. Thank you.
Special labs for your level of energy. Absolutely awesome talk.
Thank you.
But it's just what protocol you follow here. It's the like one is that regarding the lymph node examination in an endometrial carcinoma.
Yeah.
How do you go for the examination of that? And you just take one section of HE or you go further? Because we have two protocols available.
So so when a case comes for sentinel lymph node, it does not come for frozen.
Yeah.
You do the sentinel lymph node in a permanent setting. It's called sentinel lymph node, but they are processed by two protocols. One is the MSK-CC protocol and one is the MD Anderson protocol. So we follow the MSK-CC protocol where sections are, I'll share the article with a detailed picture with you, where you take those sections on the H&E sections. Yeah. And they are the intervals. I mean, it's difficult to say it right now in detail. So you follow, there's an excellent article in the International Journal of Gynae Pathology on staging of endometrial cancer by Dr. Naveena Singh, where she shows the two protocols in detail. So what we do simply is we take the deeper sections and then we put the cytokeratin. But if you see gross metastasis, you don't need to do. When you don't see gross metastasis, it's very simple. People say ultra staging karte ho. So आपने कुछ भी नहीं है, उसको deeper section लेना, थोड़े पैसे खर्च करने, and उसमें cytokeratin डालना. So that's ultra staging. But if you want to act smart, you can say, हम ultra staging करते हैं.
You do it in all the cases of the MMR?
All cases which come for
myometrial invasion.
No, no, we do it for all cases of sentinel lymph, where the sentinel lymph node is sampled, irrespective of LVSI. It might have not been grossed properly. It might, so irrespective of the LVSI, if a sample comes for sentinel lymph node or sentinel lymph node comes, we process it, we ultra stage it. All cases.
One more thing, I just want to know your experience regarding the subclonal expression.
Oh, excellent question. So the first time that I saw it was actually a few years ago. So another thing I want to tell residents, when you see strange stuff, don't be in a hurry. You want to go home at 5:30 that day, no problem, काम हो सकता है. But keep that case. They want the report. Release the case. Hold on. So that's how it happened. I saw the subclonal. I saw areas where they were completely negative, but the internal control had worked, and there were areas which were retained, and the internal control had worked. And this happens with PMS2 and MLH1 generally. So this subclonal loss is usually a somatic event. You're supposed to interpret it as subclonal loss, provided you know that where it's lost, the internal control should have worked. And that is a somatic event generally. There are papers on this, and hypomethylation is another cause for that. So you write that it is subclonal, could be because of a somatic event. Do your hypomethylation. This very rarely is because of Lynch syndrome.
Right. So
Yeah.
this goes sort of against the presence of the Lynch syndrome.
Yes, this goes against the presence.
You reported that.
I reported as subclonal.
Because right now we are not having the guidelines.
No, so if you read the, if you had, you come for the lecture to Calcutta for this.
Yeah,
No, Dr. Kuhn had given an excellent lecture.
There is an article in fact it was published, I think, recently in the Archive of Pathology and Laboratory Medicine.
Yes.
So, but I think
I'll share the article with you for subclonal loss. I will also share the Dr. Kuhn's guidelines. And there are papers. And I think BAGP also has guidelines on the P53 and the MMR IHC, and they have addressed the problem of subclonal loss. And they are somatic events not related with Lynch syndrome. I have reported on 2 to 3 of such cases.
thank you.
Promise algorithm. So those algorithms were a part which followed the TCGA studies. The algorithm tells you that what I said right in the beginning of my lecture. You want to do molecular classification. You follow a guideline. Start with poly, because poly is ultra mutated. And if that you do P53, and if everything's okay, call it NSMP. That's your algorithm. So promise or, all of these are algorithms. Why? Because there is a logic to this. First, because poly is ultra mutated, because of poly you can have MMR and P53. That's why you should do poly first. Because MMR is hyper mutated, because of that you can have P53. So then do MMR next. Because after these two are ruled out, then you do your P53, and then lastly you're left with nothing, it's NSMP. So these are just algorithms which you should follow. Now, do we do it? No, we don't. We follow something of a BAGP. I don't do poly on very low risk, because anyways it's called, ultimately patient care ke liye, everything should be for patient care. And for metastatic, there are a few patients, as I said, suppose someone has a carcinosarcoma and is receiving chemotherapy for that. In an MDT setting, it's okay to know the poly, how the patient is going to behave. He may behave very well if it's a poly-mutated carcinosarcoma. So those are, again, cost of the patient, etc. Take into account an affording, I would like to, that's in an MDT setting that the patient wants to know, or something like that. Yeah.
So we actually, this one is better, British. Promise Vancouver has
MMR, but it is better to have, it's better to do poly first because it's ultra mutated, but then MMR, then P53, and then you're left with nothing. Between the two, that's what you were asking. Okay.
MMR, I see we still have. No, we are doing the MSI only.
You're doing MSI by molecular testing or MMR?
हाँ तो NMR ऐसे तो कर रहे हैं.
Thank you, ma'am, for the elaborative talk, and you really deserve a lot of appreciation from each one of us. So, remember how far you have come, not just how far you still have to go. You may not be where you want to be, but neither are you where you used to be. So, there's a long, long way to go still, and we have to work. Yes. फिर से बोलेंगे, okay. Part of it is penned by me myself. Okay. Remember how far you have to go, not just how far you have come. You may not be where you want to be, but neither are you where you used to be. Okay. So thank you. With ma'am, you can still contact her. She is always willing to help, guide. She's there with us today. She'll be leaving tomorrow morning. We can eat her head more and take time, any extort time from her. She is available with us. But yes, not too much. We'll break for lunch. Madam will come with us. With your permission, sir, we'll take her to guest house. And I request you all to assemble in the CGR, that is the clinical grand round, at 3 p.m. in Selby Hall. Okay? And those who are in trauma or emergency postings are, of course, supposed to be carrying out those. Right? So, getting a glimpse of few cases from the humongous amount of and variety of work they do at Tata, that has just made our day, right? So, thank you all. Thank you, sir. Thank you so much for allowing us and letting us drive the way we want to, the academic sessions. Thank you so much. Sir, please. I would invite our head of the department, Professor U.S. Singh, sir, to formally thank our guest speaker. Sir, please.
On behalf of Department of Pathology, all the faculty, we do welcome and as well as we thank you enormously because of a very elaborate talk on the female genital system, especially the area which you covered today. And I think it is a great thing for the third year residents who are going to appear in the examinations. And what Madam has said, or what our teacher Madam has said, that if you have to learn an organ, then basically you go for a bit of the embryology and a bit of the normal histology of that organ. And if you see the classifications also today, or it will be keep on coming from the inherent cell whatsoever is there. So what Madam talked about the mesonephric arrest or the ducts and all that, they are not only in the cervix, you can find it in the fallopian tubes, in the lymph nodes, ovary, in the pelvis itself, likewise several other places. Now, you can learn all these ISC on the basis of the tumor, or you can go for what is the constituent cell of that particular organ. So all the organs, they are essentially having the lymphatics, also the blood vessels and the inherent stromal cells and the parenchymal cells and all that, and the rest and all that which we have described, and how do these rays they evolve into the formation of the cervix, likewise they are in the formation of the trigone of the urinary bladder, likewise in the nephron and all that. So if you know those details, you will be able to derive that whether it is a carcinoma, sarcoma, or a combination of the things, or lymphosarcoma and things likewise. As far as this was discussed over, that there was as Madam said, that there was a tumor arising from endometrium, then it lung carcinoma, then it became an abdominal mass. Now, what our perception is that there is a tumor, and this tumor is because of certain mutations. And if you remember about the mutation has a wide, you can say, expressions. So what we call that this is the primary and has gone to secondary to the lung and then to the abdomen is a one theory. It has traversed. The second is that at different time of its expression, the same thing has expressed at endometrium, the same thing has expressed at the lung site, and the same thing is getting more of the mutation, and it is getting expressed in the abdominal wall and things likewise. So that may also be a theory or a hypothesis which we can take. Now, there is nothing to say that talking 2.5 hours and without a sip of water is a great thing. And what she talked relevant, especially she has made it especially for the all the graduates who are going for the examinations. So go read in detail because she has compiled it in 2.5 hours. But the fact remains that it is you will take at least 2, 3, 4 weeks before going through in detail. Read anything you read the basics, and as Madam has guided. Thank you very much, Madam, for coming right from Calcutta, spending a few days with us. We are very grateful to you. Thank you very much. And I would request you to keep on coming on all these days. And other than these Ovarian, also we will keep on inviting you on several other occasions. And it is a great pleasure. Thank you. Thank you. जैसे जब सब थे ना पहले
यहाँ पे हो ही नहीं पाएगा
Yes, ma'am. Full screen कर दो बेटा. पहले वाला कर दो ना. ये वाला. मैम यही वाला है. चलो फोटो दिख रही है. Examination section ये गलती बच्चों के साथ बेटा लोग आ जाओ. Examination section दो एक से जाकर क्या है इसका सही करो ठीक है. हम लोग होते ही ना तो ना तो बोला कि डिपार्टमेंट की प्रॉब्लम है डिपार्टमेंट की प्रॉब्लम है लेकिन आपकी प्रॉब्लम ये है कि दूसरे पार्टी को भी दे रहे. बोला हाँ ये तो मेरे को अभी पता चला. Our son is following suit for the getting target. I have to make no lost look now.
I came totally without laptop or anything. She is the person and actually कभी रोज दिखता है उसको जस्टिस limited my job opportunities like anything. They will take a doctor and then give it to अपने ग्रुप में भी देते हैं so you take it somewhere else, right? I don't have it here. Yeah, it's very
अटैचमेंट नहीं होगा देखो अब दो दिक्कत यार ये किसका है है यहाँ का ये वाला है तो यहाँ का ये लोग भर देगा ना तो अपना लैपटॉप देने लगे हैं तो यहाँ पे तो यहाँ बताना पड़ेगा ना कि इसका मैम क्या बोली